would like to remind everyone to take time in visiting all the virtual rooms. Before we begin, here are a few reminders for all attendees. Welcome to our Midyear Convention. Reminders. All attendees are in listening mode. It is helpful to use a two-way earphones and headset for clear audio input. Lectures are in PowerPoint presentation. Device must be in full screen mode for better viewing. Questions will only be entertained during the Q&A. However, you may type your questions in the chat box addressed to the speaker or moderator while the lecture is ongoing to allow us to collate questions for the speaker to answer later. Please take note that each topic may have more than one speaker. Each speaker will have 25 minutes to present. Please answer the short feedback to claim your certificate of attendance. A survey will be emailed to you after each webinar conference via link. Breakout rooms are in place to visit and interact with our pharmaceutical partners. Our host will control the virtual breakout room visits. Please click Join in your device when breakout session starts. During the breakout sessions, look for the help icon if you need assistance. You will see this in your screen device when it is time to go back to the main session. Leave breakout room means returning to the main session. Leave meeting means you are leaving the Zoom conference. Thank you for your patience.
The Philippine Society of Gastroenterology marks its 60th year with strengthened commitment to innovate, educate, and elevate the way we connect to one another. We welcome you to this virtual touchpoint, igniting our inner strengths to meet the present challenges head-on. Together, we usher in a new decade of learning, teaching, training, and research, and valiantly face this battle we must work on to conquer.
Good afternoon and welcome to the Philippine Society of Gastroenterology's virtual Midyear Convention. Before we begin the program, attendees will be entering virtual rooms of our sponsors. We would like to remind everyone to take time in visiting all the virtual rooms. Before we begin, here are a few reminders for all attendees. Welcome to our Midyear Convention. Reminders. All attendees are in listening mode. It is helpful to use a two-way earphones and headset for clear audio input. Lectures are in PowerPoint presentation. Device must be in full screen mode for better viewing. Questions will only be entertained during the Q&A. However, you may type your questions in the chat box addressed to the speaker or moderator while the lecture is ongoing to allow us to collate questions for the speaker to answer later. Please take note that each topic may have more than one speaker. Each speaker will have 25 minutes to present. Please answer the short feedback to claim your certificate of attendance. A survey will be emailed to you after each webinar conference via link. Breakout rooms are in place to visit and interact with our pharmaceutical partners. Our host will control the virtual breakout room visits. Please click Join in your device when breakout session starts. During the breakout sessions, look for the help icon if you need assistance. You will see this in your screen device when it is time to go back to the main session. Leave breakout room means returning to the main session. Leave meeting means you are leaving the Zoom conference. Thank you for your patience.
The Philippine Society of Gastroenterology marks its 60th year with strengthened commitment to innovate, educate, and elevate the way we connect to one another. We welcome you to this virtual touchpoint, igniting our inner strengths to meet the present challenges head-on. Together, we usher in a new decade of learning, teaching, training, and research, and valiantly face this battle we must work on to conquer.
Good afternoon and welcome to the Philippine Society of Gastroenterology's virtual Midyear Convention. Before we begin the program, attendees will be entering virtual rooms of our sponsors. We would like to remind everyone to take time in visiting all the virtual rooms. Before we begin, here are a few reminders for all attendees. Welcome to our Midyear Convention. Reminders. All attendees are in listening mode. It is helpful to use a two-way earphones and headset for clear audio input. Lectures are in PowerPoint presentation. Device must be in full screen mode for better viewing. Questions will only be entertained during the Q&A. However, you may type your questions in the chat box addressed to the speaker or moderator while the lecture is ongoing to allow us to collate questions for the speaker to answer later. Please take note that each topic may have more than one speaker. Each speaker will have 25 minutes to present. Please answer the short feedback to claim your certificate of attendance. A survey will be emailed to you after each webinar conference via link. Breakout rooms are in place to visit and interact with our pharmaceutical partners. Our host will control the virtual breakout room visits. Please click Join in your device when breakout session starts. During the breakout sessions, look for the help icon if you need assistance. You will see this in your screen device when it is time to go back to the main session. Leave breakout room means returning to the main session. Leave meeting means you are leaving the Zoom conference. Thank you for your patience.
The Philippine Society of Gastroenterology marks its 60th year with strengthened commitment to innovate, educate, and elevate the way we connect to one another. We welcome you to this virtual touchpoint, igniting our inner strengths to meet the present challenges head-on. Together, we usher in a new decade of learning, teaching, training, and research, and valiantly face this battle we must work on to conquer.
Good afternoon and welcome to the Philippine Society of Gastroenterology's virtual Midyear Convention. Before we begin the program, attendees will be entering virtual rooms of our sponsors. We would like to remind everyone to take time in visiting all the virtual rooms. Before we begin, here are a few reminders for all attendees. Welcome to our Midyear Convention. Reminders. All attendees are in listening mode. It is helpful to use a two-way earphones and headset for clear audio input. Lectures are in PowerPoint presentation. Device must be in full screen mode for better viewing. Questions will only be entertained during the Q&A. However, you may type your questions in the chat box addressed to the speaker or moderator while the lecture is ongoing to allow us to collate questions for the speaker to answer later. Please take note that each topic may have more than one speaker. Each speaker will have 25 minutes to present. Please answer the short feedback to claim your certificate of attendance. A survey will be emailed to you after each webinar conference via link. Breakout rooms are in place to visit and interact with our pharmaceutical partners. Our host will control the virtual breakout room visits. Please click Join in your device when breakout session starts. During the breakout sessions, look for the help icon if you need assistance. You will see this in your screen device when it is time to go back to the main session. Leave breakout room means returning to the main session. Leave meeting means you are leaving the Zoom conference. Thank you for your patience.
The Philippine Society of Gastroenterology marks its 60th year with strengthened commitment to innovate, educate, and elevate the way we connect to one another. We welcome you to this virtual touchpoint, igniting our inner strengths to meet the present challenges head-on. Together, we usher in a new decade of learning, teaching, training, and research, and valiantly face this battle we must work on to conquer.
Good afternoon and welcome to the Philippine Society of Gastroenterology's virtual Midyear Convention. Before we begin the program, attendees will be entering virtual rooms of our sponsors. We would like to remind everyone to take time in visiting all the virtual rooms. Before we begin, here are a few reminders for all attendees. Welcome to our Midyear Convention. Reminders. All attendees are in listening mode. It is helpful to use a two-way earphones and headset for clear audio input. Lectures are in PowerPoint presentation. Device must be in full screen mode for better viewing. Questions will only be entertained during the Q&A. However, you may type your questions in the chat box addressed to the speaker or moderator while the lecture is ongoing to allow us to collate questions for the speaker to answer later. Please take note that each topic may have more than one speaker. Each speaker will have 25 minutes to present. Please answer the short feedback to claim your certificate of attendance. A survey will be emailed to you after each webinar conference via link. Breakout rooms are in place to visit and interact with our pharmaceutical partners. Our host will control the virtual breakout room visits. Please click Join in your device when breakout session starts. During the breakout sessions, look for the help icon if you need assistance. You will see this in your screen device when it is time to go back to the main session. Leave breakout room. Let us put ourselves in the holy presence of God. Heavenly Father, as we gather this afternoon, we praise, glorify, and thank you for continuously protecting and blessing each one of us and our families during this difficult time. Thank you for allowing us to meet and share our knowledge and time with one another in this convention. May you extend your divine wisdom to our speakers so that they would be able to impart effectively their God-given knowledge. Bless them as they continue to bring their expertise to people who need them. Bless each and every one this afternoon. Send unto us your Holy Spirit so we may be guided and committed to our tasks. May you bestow your blessings after this conference so that we may be able to heal and care for our patients in the spirit of your love and generosity. Rooted in your love, may your face illuminate all activities done in your name. These we ask and pray in Jesus' mighty and holy name. Amen. We now invite everyone to join us in singing the national anthem.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, kaya sa sinananan, alam ng puso, sa dikit mo'y buhay. Lupang hinirang, kuyagan ang mahiting, sa manlulupin, di ka pasisigil, sa ganagang tulong sa simoy at sa nalikang bagaw, ay hinatang tulang awit sa pagkayang minamahal, ang isang lang matawad mo'y nagbukay na nag-iibig, makituwin at araw niya kailan pang ay di mag-ibig. Lupa ng araw ng walang pansinta, buhay langit sa piling ko. Aming higaya ng bantay pag-amin, at mamatay ng dahil sa'yo.
Good afternoon, and welcome to the Philippine Society of Gastroenterology's virtual Midyear Convention. Before we officially start the program, attendees will be entering virtual rooms of our generous sponsors. We would like to remind everyone to take time in visiting all the virtual rooms to qualify for the PSG raffle. Before we begin, here are a few reminders for all attendees. Welcome to our Midyear Convention. Reminders. All attendees are in listening mode. It is helpful to use a two-way earphones and headset for clear audio input. Lectures are in PowerPoint presentation. Device must be in full screen mode for better viewing. Questions will only be entertained during the Q&A. However, you may type your questions in the chat box addressed to the speaker or moderator while the lecture is ongoing to allow us to collate questions for the speaker to answer later. Please take note that each topic may have more than one speaker. Each speaker will have 25 minutes to present. Please answer the short feedback to claim your certificate of attendance. survey will be emailed to you after each webinar conference via link. Breakout rooms are in place to visit and interact with our pharmaceutical partners. Our host will control the virtual breakout room visits. Please click Join in your device when breakout session starts. During the breakout sessions, look for the help icon if you need assistance. You will see this in your screen device when it is time to go back to the main session. Leave breakout room means returning to the main session. Leave meeting means you are leaving the Zoom conference. Thank you for your patience.
The Philippine Society of Gastroenterology marks its 60th year with strengthened commitment to innovate, educate, and elevate the way we connect to one another. We welcome you to this virtual touchpoint, igniting our inner strengths to meet the present challenges head-on. Together, we usher in a new decade of learning, teaching, training, and research, and valiantly face this battle we must work on to conquer.
Once again, good afternoon and welcome to the Philippine Society of Gastroenterology's virtual Midyear Convention. To officially open our webinar, let us all welcome the President of PSG, Dr. Augusto Jose Galang.
Good afternoon. I would like to welcome everyone to this year's Midyear Convention as represented by a two-part webinar series. Our last Midyear Convention in Cebu City 2 years ago was held back-to-back with the Asia-Pacific Association of Gastroenterology or APEG Clinical Forum on Inflammatory Bowel Disease. This year, the Midyear Convention Organizing Committee has diligently prepared relevant topics that address the issues that our members currently face in the light of the current pandemic. I would like to thank and congratulate our second Vice President, Dr. Alan Policarpio and his team, who have worked unconventionally these past months or weeks to offer to us a worthwhile scientific activity amidst the challenges of COVID-19. I also take this opportunity to express my gratitude to our partners in the pharmaceutical industry, who have stayed loyal to support us despite major obstacles this year in realizing revenues and meaningful engagement with our members in the respective clinics. I am confident that this upcoming two-part webinar series, plus our successful 10-10-2020 virtual anniversary celebration 2 weeks ago, will make our mid-year activities this year as memorable as the last one in 2018. Finally, I would like to officially announce an additional medium to reach out to our members and the communities we serve. Aside from our website, psgastro.org, please subscribe to our YouTube channel, PSG Cares. It will be a repository of our recorded videos that will include all our webinars, including this convention. We also encourage our younger SOCMED-savvy members to contribute to this channel so we can generate more materials and make them available for everyone. Thank you very much.
Thank you, Dr. Galang. And now, to welcome everyone to our online gathering is Second Vice President of PSG, Dr. Alan Policarpio.
Good afternoon, my dear colleagues. Welcome to our Midyear Convention. As the chair of the 2020 PSG Midyear Convention, iGutCOVID, we have come up with timely, well-thought topics relevant to our daily practice, as they say, the new normal. This is a two-series virtual scientific event happening today and on next Saturday, October 31, at the same time, from 4 o'clock in the afternoon to 8:15 in the evening. The challenges of organizing a convention has never been more magnified with the situation that we are faced with. But despite it all, the organizing committee has embraced the challenge of putting together a roster of distinguished speakers to update and bring us new knowledge on 4 important and practical topics. GI bleeding in the time of pandemic, COVID-19 testing, who, what, and when, PPI use in COVID patients, friend or foe, the global race to COVID-19 vaccine, will it be the end of the pandemic? I know for a fact that our speakers were also confronted with difficulty in coping with their busy schedules while preparing for their presentations. We all know that with the continuous updates and changes about the pandemic, it has evolved because it has affected our lives, our practice, and even human relationships. What is new now may be obsolete after a day or two, so I urge everyone to take this opportunity to listen, to ask, to interact and learn with our experts. Our pharmaceutical friends have also prepared different activities during our breakout sessions. I encourage everyone to please visit their virtual breakout rooms. This being said, I would like to sincerely thank our organizing committee for preparing iGutCOVID for us. Thank you to our distinguished speakers for sharing their knowledge and expertise. To our dear friends from the pharmaceutical industry for their unwavering support to our beloved society, for all their help in all our CME activities. Thank you very much. To the current officers on board, thank you for all your support. And lastly, to our beloved society, the Philippine Society of Gastroenterology, thank you for this wonderful opportunity to be of service to you. Again, welcome, and may God bless us all.
Thank you, Dr. Policarpio. We now kick off our mid-year convention with the first lecture. To introduce the speakers for our first topic and to facilitate our Q&A later is our moderator. He obtained his medical degree from Manila Central University. He had his residency in internal medicine at Cardinal Santos Medical Center and completed his fellowship training in gastroenterology at University of the East Ramon Magsaysay Memorial Medical Center. He is past training officer of the section of gastroenterology at the University of the East Ramon Magsaysay Memorial Medical Center. Currently, he is a member of the specialty board of the PSG-PSDE. One of our moderators for this webinar is Dr. Gentry D.
Good day and welcome to the first virtual mid-year convention of the Philippine Society of Gastroenterology, iGutCOVID. You know, I'm very excited for today's topic because we all know how COVID has affected our practices, particularly in how we manage GI bleeding. Has COVID changed the etiology or cause of GI bleeding in our practice? As far as management of GI bleeding is concerned, has this affected the morbidity and mortality? And finally, what are the challenges in managing GI bleeding? Our first speaker is a well-sought-after speaker. Is Dr. Bhavesh Kishore Doshi. He obtained his basic medical degree from Nottingham University, United Kingdom. He attained membership of the Royal Colleges of Physicians of the UK, and later achieved his certificate in completion in gastroenterology and internal medicine from Liverpool, United Kingdom. He then underwent advanced fellowship for ERCP and EUS in Liverpool. Currently, he is a senior consultant, Division of Gastroenterology and Hepatology, National University Hospital, and an assistant professor at the Department of Gastroenterology and Hepatology, National University of Singapore. He is also the director of the Singapore Hands-on Live Endoscopy course, SHOLEC, as well as the director of endoscopy training in National University Hospital. As a clinician, Dr. Doshi's main focus has always been patient care and continuously provide both diagnostic and advanced therapeutic gastrointestinal care for his patients. Friends, let's all welcome Dr. Bhavesh Doshi.
Hello, thank you very much for this kind invitation. I'm just going to share my slides. I'm sorry, just bear with me a moment. Can everyone see the slides?
Yes, Dr. Doshi, we see your slides.
Okay, brilliant. So do you see the main slide or the presenter view?
Oh, we lost it. We lost your slides.
Okay.
We're seeing you.
You're seeing me? Let me
Yes, not your slides.
Let me see if I can get it going again. Can you see my slides again?
Yes, now we can see them now.
Okay, great, brilliant. So first of all, thank you to the Philippines GI Society, the organizers and the moderators for giving me this opportunity to talk about GI bleeding in the time of COVID pandemic and the new normal, basically. I think a big shout out to all the healthcare workers who've been working to look after patients, not just with COVID, but to look after regular patients with their regular conditions. And I think it's a testament of the character and the strength of individuals who are continuing to help others. So big shout out to them. So the objective of this talk is there's several objectives. So the main topics are background of GI bleeding amongst COVID patients. We'll look at the incidence, the causes, perhaps the risk stratification, and see how we can manage these patients better if we know the ones that are at risk of bleeding. The topic of anticoagulation, PPI prophylaxis. We talk about conservative approach, i.e. not scoping these patients, or perhaps an early or late endoscopy. We'll touch on some of the challenges in managing some of these patients with testing, equipment, resources, the society guidelines, and finally with staff attrition rates and staff infection rates. So coronavirus or COVID-19 is a pandemic that's been caused by the severe acute respiratory syndrome coronavirus type 2 and has affected more than 5 million patients worldwide. The problem with this condition is that the clinical manifestations are wide-ranging. Some patients may have simple flu-like symptoms. Some people might have serious multi-system disorders with high fatality in that particular group. Coagulation abnormalities seem to be increased in, particularly in the sicker patients, and up to 30% of patients may have thromboembolic events. Now, many of these patients are receiving anticoagulation. And we know that GI bleeding is a common complication in these patients who have anticoagulation on board. So GI bleeding in COVID can be divided between primary cause, which is mucosal damage from viral invasion or tissue hypoxia caused by the virus itself or with a direct effect on the tissue. And secondary causes, which are usually related to coagulopathy, which the patient might develop as a result of either the patient's hematological problems or because of medications such as antiplatelets and anticoagulation treatment, which is often given to these patients. So in terms of overall prevalence of GI bleed amongst COVID patients, several studies have reported this directly or indirectly, and it's not that clear, but the data seems to suggest a range of around 0.4 to 4%. The majority of these patients have bleeding that occurs after 24 hours from admission, which may suggest that the bleeding might be from some of the secondary factors such as anticoagulation. And a large fraction of patients with GI bleeding have received some anticoagulation, although when compared to patients without GI bleeding, there isn't a significant statistical difference, at least in some of the studies that have come out. The location of this bleeding can vary. It can be our standard peptic ulcer disease to some more rare and unusual conditions such as ischemic colitis or segmental colitis, other lesions such as esophagitis, hemorrhagic gastritis, variceal bleeding and decompensated liver disease, Delafoy, and other rare causes can be seen and have been reported in COVID patients. The important thing is that if the majority of the patients are bleeding more than 24 hours after admission, then is there a way that we can risk stratify this group and perhaps try to reduce or minimize their risk of bleeding? And so several studies have looked at this. I think to start with, most of us can probably get data from non-COVID patients and extrapolate that to COVID patients. I think patients who are on anticoagulation, older patients, patients at risk or previous history of GI bleeding, chronic renal impairment, H. pylori infection, concomitant use of antiplatelet drugs, and pre-existing gastrointestinal tract lesions might be at higher risk. And so we know that this group may need additional protection, perhaps PPIs, perhaps more intensive monitoring and looking out for early signs of GI bleeding so that we might be able to adjust their medications. So this study looked at 95 patients with GI symptoms of COVID infection. And what they were looking at was to identify factors such as fecal RNA positivity indicating a more severe disease, or perhaps mucosal biopsies with COVID-19 RNA. And what they found was that fecal RNA doesn't seem to indicate a more severe GI disease, but perhaps mucosal biopsies in patients with severe GI symptoms or mucosal biopsy positivity might indicate more significant or serious GI symptoms. But I don't think we'd be able to scope everyone to with COVID to identify the risk factors for GI disease. So I think this other study was a multi-center retrospective study looking at 400 patients who were admitted with COVID, and there were majority of these patients were receiving anticoagulation. And what they found was that when they looked at all-cause bleeding, The two determining factors were D-dimers, raised D-dimers at presentation, and also low platelet count. So perhaps this might be an early sort of warning system for these patients that might be at risk of bleeding and that might need to have more additional monitoring. Should we avoid anticoagulation in COVID patients? I mean, given that we know that they are at an increased risk of bleeding, should we be anticoagulating the patients at all? And I think the study on the left shows that this was a study of almost 4,400 patients, mean age of about 65, and essentially about 1,500 patients did not have anticoagulation. So about 35% of patients did not have anticoagulation. About 20% had therapeutic anticoagulation, and about 44 or 45% had prophylactic anticoagulation. And what they showed was that there was a significant improvement in mortality in patients who had some form of anticoagulation versus no anticoagulation. So I think it's pretty clear that in patients that have COVID, who have indications for anticoagulation, there is a significant benefit to mortality when you anticoagulate them. This study on the right was a single center retrospective analysis of 355 patients, majority of which were anticoagulated. And if you bear with me with the table there, it's slightly confusing, but essentially in patients who were anticoagulated, the risk of bleeding, risk of death from bleeding, all-cause bleeding, was significantly higher. But when they looked at GI bleeding, they found that death was no different versus patients with no GI bleeding. So if you were anticoagulating these patients, then if they bled from the GI tract, there was no significant increase in mortality in this group. So I think overall, most doctors would believe that anticoagulating these patients is beneficial. Now, we might need to stop the anticoagulation if the patient starts bleeding, but generally it should not be a reason to withhold permanently the anticoagulation. So PPI prophylaxis for at-risk individuals, and this was expert opinion from a group that looked at preventing GI bleeding. They suggested that we identify patients at high risk of GI bleeding. So the features that we mentioned already, if these patients had previous history of upper GI bleeding, peptic ulcers, history of H. pylori, and they needed anticoagulation, then perhaps we could anticoagulate them, but keep them on PPI prophylaxis, perhaps even do serological or breath testing for these patients to detect H. pylori and to treat them if they were positive, so that we could minimize their risk of subsequent bleeding. In patients who had in patients who were on antiplatelet agents or NSAIDs, the recommendation was to try to see if we could stop the medication so that we could anticoagulate them safely. But if we could not stop it, then they should be covered with adequate dose of PPIs. Next question is there a need for urgent endoscopy in GI bleeding for COVID cases? And again, this was a study that came out of the States that looked at 41 patients with GI bleeding in COVID, matched against 82 individuals with COVID without GI bleeding. And the primary objective was to characterize the bleeding etiologies. Secondary objective was to discuss the outcomes and therapeutic approaches. And essentially, out of the 41 patients that had the GI bleed, 10 patients underwent endoscopy, but only 4 patients required intervention, endoscopic intervention. They found that there was actually no difference in transfusion rates, despite having similar GBS scores in both groups, both the endoscopy group and the non-endoscopy group. There was actually no significant difference in mortality or significant outcomes, or even in transfusion requirements. So I think this was suggestive that perhaps even conservative medical management in these patients might be beneficial rather than undergoing endoscopy. This was a study from Italy that looked at 4,871 patients with COVID. And 23 of these patients had signs of upper GI bleeding. So this gave an incidence of about 0.5%. The majority were on anticoagulant therapy or thromboprophylaxis. 11 patients underwent early endoscopy within 24 hours, and 12 patients underwent either delayed endoscopy more than 24 hours later, or no endoscopy was performed. Now, when they looked at the comorbidities in both groups, there was no statistical significant difference. And both groups had anticoagulation. In fact, the delayed or no endoscopy group were actually, there were more people in that group that were actually anticoagulated than the early endoscopy group. And essentially what they showed was that there was no difference in mortality and rebleeding rates between the two groups. So whether they went through early endoscopy or delayed or no endoscopy, there was actually no difference in mortality. What we'd expect, though, is that there was an increased need for endoscopic intervention in the patients that had an early endoscopy. This is because the PPIs hadn't had a chance to work. In all of these patients that underwent the bleeding, the anticoagulation was stopped. So that makes sense to reduce their risk of having complications. But as I mentioned, the GBS score, the Glasgow-Blanchford score, was no different in both groups. So based on this, they proposed an algorithm for management of GI bleeding. So in patients with signs of upper GI bleeding in COVID patients, the priority for normal patients is to start IV PPI, hemodynamic support, and withdraw the anticoagulant or antiplatelet agent. They suggested that patients that had minimal oxygen requirement could undergo an endoscopy if required. In patients with high oxygen requirement, but who could be medically managed and signs that the bleeding was controlled, either hemodynamically or absence of melena or no hematemesis, the need for endoscopy could be reevaluated. If the bleeding was uncontrolled, so if they were persistently having melena or hematemesis or blood in the NG tube, then this group required an urgent endoscopy. And in patients with active hematemesis, they would more than likely need an urgent upper GI endoscopy because of the risk of varicose bleeding. So the key question is, do all patients actually need endoscopy? So this was a study, a retrospective analysis of 24 bleeds in 1,342 patients, 1.8% prevalence of bleeding in COVID-19 patients. The mean age of this group was significantly lower than in the Italian study. Italian study mean age was 75. The mean age in this group was 45, so much younger patients. The majority of the patients were male, and the majority of the location of the bleed was the upper GI tract. They were all managed conservatively. And what the study showed was that there was no rebleeds at day 5. And provided they were medically managed with withdrawal of anticoagulation and PPI therapy, there were no increased risk of death in this group. So I think we may have to reevaluate how we manage these patients. We may have to approach a more, or do it in a more conservative approach, provided the patients respond to medical management, and only reserve endoscopy for the high risk group. The patients that are not responding to medical management or having persistent bleed. And even then, I think there are options, not just endoscopy, but perhaps interventional radiology to reduce or minimize the aerosol contamination. So I think it's worth considering other options in this group of patients that are not responding medically. The AGA have come up with some recommendations for patients who are undergoing endoscopy during this COVID pandemic. And I think across the board, regardless of whether your patients have COVID or suspected or not suspected or asymptomatic, I think all patients who are undergoing endoscopy, the doctors and nurses and staff in the room have to have N95 mask on. I think in patients who have confirmed or highly suspected COVID, at least our protocol in Singapore and in NUH has been to have PAPR ventilators for the healthcare staff in the room to reduce their risk, in addition to the usage of N95 masks. Surgical mask is not an appropriate protection. The recommendation from the AGA is also double gloving for endoscopy. In confirmed cases, the recommendation is to use a negative pressure room, so to prevent the aerosolize or prevent the spread of the aerosol COVID infection outside of the room. The endoscopy disinfection process continues to be the same. And there is a strong recommendation for triaging these patients. So determining whether these patients actually need an urgent endoscopy or not, or whether they need an endoscopy at any stage. So we have different equipment available, different variations of N95 masks. I think I can only speak for a Singapore experience. I'm not entirely aware of what the situation is worldwide. But in the Singapore experience, we have access to the N95 mask. We have the most common, the M green N95 mask. This is locally made in Singapore, so we've had access to it. We also have access to the more sort of softer fabric, which is a more comfortable fit for our staff. And this is a made in UK M product. Again, at the moment, it's readily available and has been readily available for us. But there are many different masks available on the market, and I think individual institutions and countries have their own devices. So in terms of PAPR device, this is what we use in NUH. We have a simple ventilator device which we strap on to the waist. This has several high efficiency air filters installed. Contains a battery pack which is permanently charged. This is connected to a hose, which is then connected to a hood that the operator and the healthcare workers in the room would use in patients with COVID who are undergoing endoscopy. Now the hood is not airtight. This is our device. This is one of our operators who used it for GI bleed in a patient with COVID. It's not an airtight hood. It is essentially just a positive pressure device. So it maintains clean airflow into the hood and prevents any contaminated air from entering the hood. And this is in addition to the N95 mask that we would wear. On top of that, we would wear a gown. Now this photo doesn't have the gown on because I wanted to show where this ventilator straps on. But we would wear a foolproof, waterproof gown, and we would have shoe protection, waterproof shoe protection also. So that is our PAPR equipment in NUH. Speaking of PAPR equipment, when we looked, or when studies have looked at the risk of COVID amongst frontline healthcare workers, this was one of the largest studies, which was a prospective observational study of over 2 million individuals with self-reporting over smartphone application of COVID infection. They found that there was at least a 3-time increased risk of developing COVID in healthcare workers. And this risk could not be brought down back to baseline in the community despite the free availability of personal protective equipment and active strategies that are implemented to prevent COVID infection. So despite all of these measures, we could not, or the study showed that they could not bring the rate down back to the community levels. So healthcare workers are at an increased risk, and in particular groups from ethnic minorities, Asian population, Black population, are at a much higher risk of developing COVID. Just moving on to a statement from the Asia Pacific Society. I think one of the important statements was that urgent endoscopies for GI bleed should be performed by strategically assigned staff to minimize concomitant exposure. Now, this is not so easy to implement. We ourselves have had a GI bleed team. We have inpatient GI bleed team. We have an on-call GI bleed team, but we haven't been able to segregate this group. We have had segregation between inpatient and outpatient cover, but we haven't been able to minimize and create a dedicated group for GI bleed in COVID patients. Our GI bleed group has essentially been across the board for all our patients. What about the role of pre-testing strategy in asymptomatic individuals? So do we need to test everyone who's coming in for an endoscopy? They've had melena 3 days ago and they're coming in for a scope now. Should we be testing them if they have no symptoms of COVID? And I think this depends, according to the AGA, this depends on the prevalence of COVID in the community. If the prevalence is intermediate, then there may be beneficial effects of testing to determine whether an individual has COVID and to implement more robust endoscopy protocols on these individuals. But in endoscopy centers where there is low prevalence, then the recommendation is against testing, and simple reason being that the false positives will significantly affect the protocols in terms of managing these patients. So if you have low prevalence and you have high false positives, then you might be taking unnecessary precautions in some individuals. And again, likewise, in high prevalence areas, you should assume that everyone has it. And I think the need for pre-endoscopy testing is not so strong. And again, they recommend against testing, at least serologically, in individuals or endoscopy staff. So I think if we look at the take-home points, I think what we should be doing is looking out and identifying high-risk individuals for GI bleed in COVID, and perhaps prophylactically managing them with close monitoring, PPI therapy, and early stoppage of the anticoagulation if there's signs of GI bleeding. But if there aren't any signs of GI bleeding, then we should continue with the anticoagulation. Delaying scopes may not be detrimental to them, particularly if they're responding medically. I think staff allocation and distribution is important, and if your facility has manpower, then that's something that you should do. And having readily available access to personal protective equipment is absolutely crucial for an effective service. Thank you very much.
Thank you, Dr. Doshi. We'll move on to our next speaker. Our second speaker, having graduated with a degree of Doctor of Medicine from the University of the Philippines. He took up his residency in internal medicine as well as fellowship in gastroenterology at the Philippine General Hospital, after which he went to California Pacific Medical Center in San Francisco for his training in endoscopic retrograde cholangiopancreatography as well as in endoscopic ultrasound. He was the past training program director of the section of gastroenterology, UPPGH, and has served as the past president of the Philippine Society of Digestive Endoscopy. Currently, he is an associate professor in the College of Medicine. He is also the section head for advanced endoscopy in PGH, as well as the endoscopy unit head in the National Kidney and Transplant Institute. He is also currently serving as counselor of the Asia Pacific Society of Digestive Endoscopy. Let's all welcome Dr. Mark Anthony De Lusong as he gives us his insights on GI bleeding in the time of pandemic, the new normal.
Good afternoon, everybody. Thank you for joining us for this scheduled webinar. I'd like to thank the Philippine Society of Gastroenterology and congratulate them for a wonderful conference, this webinar conference. I'd like to thank them for honoring me with giving me a talk on my experience about GI bleeding among COVID patients. So these are my disclosures. Unfortunately, I don't have any. My objectives for this talk would be to discuss the common causes of upper GI bleeding I saw among COVID patients and discuss the management of such patients and also discuss the challenges I faced during the management of upper GI bleeding in these COVID patients. So it all started in China, the COVID virus. And we now all know that about 50% of COVID-19 cases, viral elements, can present in your fecal samples or of infected patients. The virus itself may cause disorders of the intestinal flora, which could result in diarrhea or even nausea and vomiting, and generally explain by what we now call the gut-lung axis. But the question is GI bleeding a presentation of COVID-19? So from numerous reports from the start of the COVID pandemic, it is actually not one of the common presentations. And these uncommon presentation of GI bleeding for COVID-19 are relegated to case reports. But of course, my talk is the common causes of GI bleeding in COVID patients. So let's concentrate there. If we look at the census of EGDs in other countries, such as in the USA, particularly in New Mexico, you would see that their endoscopy volumes, particularly the EGDs, the number of EGDs, have gone down drastically to about just 30% or even lesser than their usual numbers. Comparing them to our local experience, to my local experience in the 3 hospitals I practice in, from 2019 numbers of almost 1,700, our cases have gone down to less than 62% or 623, which is of course because of the COVID pandemic. And decreasing the numbers will hopefully decrease the transmission of this virus. That's why it has gone down. But still, the 5 indications for EGD includes GI bleeding as the top cause for doing EGDs. It is at 47.9% among these hospitals I've been practicing in. Of all the endoscopies we did from these 3 hospitals and superimposing the number of COVID patients, you will see that COVID cases are still very few. But looking at all the COVID patients and seeing how many GI bleeders there were in these COVID patients, we noted a total of 52 COVID patients with upper GI bleeding. Well, GI bleeding in general. Upper GI bleeding was noted in 45, lower GI bleeding in 6, and occult GI bleeding in 1. Looking closely at the upper GI bleeders, the findings were notable in terms of that they are the same as our regular GI bleeders. The most common culprits are still gastro or duodenal ulcers at 85%, and a very small percentage of which were caused by esophageal varices or gastric varices. And we did endoscopic intervention using hemoclips most of the time and injection sclerotherapy using epinephrine more than 3/4 of the time. And unsurprisingly, the mortality rates are very low. So only 1 died due to GI bleeding, and the rest of the 5 total mortalities died because of respiratory complications from COVID pneumonia. So again, most common are GU and TUs and gastric varices, and the mortality rates are very low. Comparing this with cases abroad in the USA, particularly in New York, where they also did very few endoscopies for COVID patients with GI bleeding, upper and lower, they noted the same findings that the usual causes of GI bleeding in COVID patients are still the usual gastroduodenal ulcers, esophagitis, etc. And their in-hospital mortality was also very low as well. So in essence, when reviewing all of this data from abroad and then locally from the hospital data from where I practice in these three hospitals, I noted the following in comparing COVID versus non-COVID bleeders. First, there were no difference in presenting symptoms. Mostly, they presented with melena, about 70 to 80% of them. And unsurprisingly, more EGDs were performed for non-COVID bleeders than for COVID bleeders. Because of course, we are scared to transmit the virus again. But for COVID bleeders, when we did the EGD, it is usually because of hematemesis. Because we are scared that the bleeding might be a strong one and caused by varices. That's why we did the endoscopy. That's my assumption. The most common cause of these GI bleeders are, again, usually bleeding gastric or duodenal ulcers and comparable with foreign or international data. Not surprising as well is that most bleeding COVID patients were on anticoagulation because, as we all know by now, this is one of the standard treatments for COVID pneumonia because of the thrombotic phenomenon caused by COVID. And in this article, in which it delved on anticoagulation and bleeding risk in patients with COVID-19, Professor Nancy Musoke noted that there was indeed increased bleeding in COVID patients given anticoagulation, particularly intracranial and pulmonary bleeding compared to those patients, COVID patients, who did not receive anticoagulation. But it is also of note that there was no increase for GI bleeding among these patients. COVID, non-COVID, who were given anticoagulants or not, all had the same frequency and rates of GI bleeding. Furthermore, comparing COVID and non-COVID bleeders in terms of outcomes, there were no difference in rebleeding rates or transfusion requirements. There were no difference in repeat endoscopy rates. And of course, COVID bleeders tend to have a longer hospital stay, not because of the bleeders, but because of their underlying condition, which is COVID pneumonia. Finally, this is also surprising. Again, there were no difference in mortality rates. Most bleeding COVID patients died of respiratory failure and not of the GI bleeding per se. Let us now proceed on how we manage GI bleeding in our COVID patients locally. The cornerstone of management is, of course, still ABCs first, don't forget. So you have to protect the airway, make it patent always. Make sure that your patient is breathing adequately by supplementing with oxygen via bag, mask, or even if you need to intubate, you intubate. And of course, you have to have adequate circulation for your patient who is bleeding, to transfuse blood, of course, and to hydrate as needed. After stabilizing your patient, now you think about the diagnosis. Is this a variceal bleed or a non-variceal bleed? Because the management is different. If it's a variceal or a non-variceal, and the major causes for non-variceal bleeding is, of course, a bleeding peptic ulcer. And the major cause for variceal, of course, is esophagogastric varices. We then think about giving a PPI via drip or IV boluses, or give somatostatin or its analogs. Sometimes we think of giving both as well if we're not sure if it's a bleeding peptic ulcer, if it's a varix, or if it's both. Finally, we then go to a conundrum. Do I scope or do I not scope? If you scope, you fall back on your diagnosis. If you think it's an ulcer, then you prepare for an injection, thermal therapy, or even hemoclips as your intervention. If you think the bleeder is a varix, then you do RBL or rubber band ligation, and even prepare glue if you think there is gastric varices that is bleeding. But all in all, the most important thing to consider is that will this endoscopy benefit my patient more than harm my patient? And then you decide if you want to go scoping or not scope. So again, ultimately, you decide if you scope. But if you scope, you decide to scope, the next question now is, do I scope now or do I scope later? So data from abroad, from their experiences with GI bleeding in COVID patients, particularly again in this article in New York, they looked at endoscopy data before COVID and during COVID, then noted hospital stay rates, transfusion requirements, and mortality rates. Kim et al. Noted that comparing the endoscopies during the pandemic and before the pandemic, they noted obviously a drastic decrease in their endoscopies performed. But again, the inpatient mortalities were no different. Again, this is a repeated data that is being reported all over the world, that inpatient mortality, whether COVID or non-COVID GI bleeders, remain the same. And in an earlier report of upper GI bleeders and COVID-19 pneumonia patients, where management only included IV PPI and clinical observation, and no patients requiring urgent endoscopy during their hospitalization. Because during the early times, of course, they were afraid of this COVID-19 pneumonia. So as much as possible, they did not want to undergo an aerosolizing procedure such as an endoscopy. And the rationale for this conservative approach was based mostly on data that suggested that delaying endoscopy for more than 24 hours was not associated with increased mortality in patients with acute upper GI bleeding in non-COVID patients back about a few years ago, as reported by Professor James Lau of the Hong Kong group. In Italy, they reported the same thing. If you do endoscopy within 24 hours versus doing endoscopy after 24 hours in COVID-19 patients with upper GI bleeding, they noted that there was no difference in mortality rates. The only caveat among these data is that the numbers are not that big because, again, COVID patients who are bleeding are not many, there are only a few. But again, the repeated reports of mortality rates being equal is of note. Early reports during the COVID-19 pandemic also suggested strategies to actually just defer endoscopic evaluation and not just do it anymore. Some centers adopted medical therapy for suspected non-variceal upper GI bleeding, including IV PPI, antiemetics, and just optimizing coagulation status. This was first reported by Professor Kimberly Cavalier, in which she was the first to report the conservative management of GI bleeding in COVID patients. All patients were in the ICU or critical care. All patients were either transfused, given PPIs, and just were given supportive care. Surprisingly, all 6 patients survived. Looking at their data, these 6 patients all had something in common. First is that most of them had just melena. Most of them were just transfused a maximum of 2 units of packed RBCs. And eventually, all of them had their GI bleeding resolved, and most of them, or actually all of them, were discharged without any mortality reports. With these reports and data that were presented during the past few months in these early stages of recovery from COVID, you may opt to delay or conservatize GI bleeding if you have a COVID patient with the following. Patient only presents with melena, and the drop in hemoglobin is less than 2 grams per deciliter from your baseline. patient is non-transfusion requiring. And you also think about if the patient is in respiratory distress, because if you scope a patient in respiratory distress, you might end up intubating the patient, sending the patient to ICU. And if you have limited ICU beds, limited PPEs, and limited staff, that may put a stress on your hospital. On the other side, you may do urgent endoscopy in bleeders, even in a patient positive for COVID, for the following. You have a low community risk and a lot of PPEs, a lot of supply of PPEs. Second, the patient has the presentation of hematemesis with suspicion of variceal bleeding. Because as we all know, variceal bleeding, if not, if we don't do endoscopy within 24 hours, the chances of mortality increases. Number 3, the known cause of bleeding is known. So you know the cause of bleeding. And endoscopic intervention with your clinical evaluation will increase patient survival. So you do it because based on your evaluation, that will save the patient. Ultimately, it's all based down on your clinical evaluation that the benefits of this endoscopy outweighs the risks it entails. Finally, let's talk about the challenges in managing GI bleeding in COVID patients. So these are a lot of challenges during this COVID pandemic because this is new to all of us. So let me share my experience and how I manage all of these challenges. The major challenge that you always think about when I was head of endoscopy in National Kidney Transplant Institute is this. The only major challenge is not to get infected and not infect others, the patients and my staff. So the first challenge is to limit, to triage, and to select patients so that you'll have only a very few number of procedures that are really needed and thus decreasing the chances of transmission. With the PSTE guidelines on indications of endoscopy during COVID, which I was also a part of, we actually just did urgent and emergent endoscopies and a few semi-urgent endoscopies during the height of the COVID pandemic. So among these are, of course, acute GI bleeding, which we are discussing, but we also treated acute cholangitis, etc., etc. We did not do elective endoscopies during the first few months and only did elective endoscopies when we were actually familiar with the protocols, with how we properly don PPEs, and when we were sure of what we're doing. Screening endoscopies obviously decreased because they can be deferred, but hopefully by the end of October when GCQ is lifted, the numbers for screening will dramatically increase so that we can help our countrymen again in decreasing colon cancer and the early GI cancers in the Philippines. So we based it largely on community risk levels and stratification. This means that if your case doubling time is less than 30 days, meaning you double your numbers every month, then the community risk level is still high and you should still limit the patients. But if your case doubling time is more than 30 days and your critical care utilization rate is less than 30%, meaning the ICU beds, the wards, etc., are not that utilized much anymore, then you can think of opening everything to your procedures, elective or not. The next question is of limiting, triaging, etc., is to do pre-procedure RT-PCR COVID-19 testing, which I think will be discussed by Dr. Derek Lee. The rationale for this is that COVID-19 is best diagnosed with PCR testing. And if you're going to do semi-urgent, even elective cases, there's still time to do the testing before you do your procedure. If the patient is an emergency case, obviously you do it even without RT-PCR COVID test, but you still do it and then follow up. And then you just treat the patient as a COVID positive patient. The drawbacks is that not all hospitals have readily available RT-PCR swabbing in their own hospitals. And of course, there's still significant false negative results with PCR testing, but it's the best we got. How about thinking about the economic burden of this testing before endoscopy? So since a lot of my staff in NKTI were asking if we should do away with the test because it's very expensive, especially in the initial months of the COVID pandemic. So this study by Corral in August of 2020, he analyzed COVID-19 PCR testing before endoscopy and did an economic analysis. And his results noted that using the test, isolate, and scope system was really expensive to do before endoscopy. It gives you burden of increased expenses both to the patient and to the hospital. However, it was noted that using this system, less healthcare workers, including nurses, doctors, and allied medical professionals who were at the front line treating COVID patients, will be less infected using this system. Thus, it may be expensive, but in the long run, it saves lives. And his final conclusion was it's ideal to use this during increased transmission rates, meaning again, your case doubling time is less than 30 days. The other thing that you should think about when you accept your patient is the consent, because now it has changed to include the risk of acquiring COVID. If your patient is not comfortable with doing the endoscopy because he or she might get COVID, then he should not undergo the procedure, especially if it's just an elective or semi-urgent procedure. At the other side of the spectrum, you can also have patients lying about their history, about their symptoms, about their exposure, and thus they may actually infect others. So that's the problem with the consent. The number 2 challenge is PPEs. How to maintain the supply of PPEs and proper use of PPEs. We have been bombarded with what level 2, level 3, or level 4 PPEs are. But now the question is, how do you maintain adequate supplies of PPE? How do you maintain that you always have something to protect you with when you do endoscopy? So what we did in our endoscopy unit, is that we had to be very vigilant in counting our supplies. We knew the numbers of our inventory. We knew how much we had, and we knew how much we used. So you always have to count supply versus usage. And then we ordered and bought in advance the PPEs based on the usage. For example, if you used 100 PPEs this month, we ordered 100 in advance, and sometimes we added a buffer, like 120. Donations will also help a lot, but you should actually delegate them as Plan B. If your normal supplies have been exhausted, then you grab your donations. But you also have to watch out for pilferage, because nurses, even doctors, bring home PPEs for use for their families, for their friends, for their loved ones. So you have to be vigilant about it and be strict about it, that the PPEs are supposed to be used inside the endoscopy unit or the hospital alone. How about the question of recycling? So again, I was asked that in my endoscopy, should be recycled. Since we had a lot of PPE supplies, a lot of donations, I opted not to recycle, and we still were able to get by. And I would advise that you recycle only if you have very short supplies. Okay? Because the dictum I think in most endoscopies, even today when the COVID pandemic is slowing down, is that if you don't have PPE, then don't do endoscopy. No PPE, no endoscopy. But why do we need so much PPE? Because we know that COVID-19 is highly infective, very fine droplets, and our procedures are AGP or aerosol generating procedures. The patient himself or herself is aerosol generating. The eyes, nose, and mouth are entry sites, so we have to protect everything. Thus, we have to teach our staff proper usage to decrease breach incidents and minimize COVID transmission. So that's another challenge. So I trained my endoscopy team to practice proper donning and then proper doffing. And then they did return demonstration to check for their competency and to test if they're really good at donning and doffing properly. We then simulated patient care activity. Even though there was no patient, we practiced donning, we practiced doing endoscopy, and then we practiced doffing and looked at the system if there was problems while doing it. To understand physical difficulties as well while wearing PPEs. The third is we enforce a buddy system or what we call tagasita. Because once a person has been very familiar with donning and doffing, he might become lax. So if a person is there watching you, he will say that you're doing it wrong, please do it properly. And that will save lives and save you from transmitting the virus or getting the virus. And finally, we also designated spaces for donning and doffing in separate areas to prevent, of course, cross-contamination. The challenge of minimizing aerosolization, contamination, and transmission of COVID in the endoscopy room is one of the more challenging challenges. But how to protect a patient and the healthcare worker? So don't forget that even though you are the one doing the endoscopy, always remember that a patient might get infected as well. So also think about protecting the patient. So we all know EGD has been unanimously agreed upon as an AGP procedure. In a COVID patient, gagging, coughing during intubation, even maneuvering of the scope, insufflation and flushing can aerosolize particles. Even just inserting a biopsy forceps into the channel and removing that instrument through the channel can cause aerosolization of particles. So how do we address this aerosolization? We did a lot of thinking of how we can decrease this aerosolization of virus. Our anesthesia team actually suggested that we ask our EGD patients to gargle with a closed mouth and swallow chlorhexidine or hydrogen peroxide before doing the procedure because they showed studies that it can actually decrease the viral load in the mouth and in the throat. We also did place a drape or a cover over the patient's head during endoscopy. Just like you have a face shield, patient had a drape so that if he or she coughs or sneezes or whatever, at least there's a physical barrier. We also sedated most patients, but not all patients were intubated. And we only scope once the patient is fully sedated and without a gag reflex. We minimized air and suctioning and minimized the splatter of accessories going in out of the endoscopy channel by using a lot of operating sponges or gauzes. Most of the time, the consultant will do the procedure, especially in private settings. Even in university settings, in teaching hospitals, the procedure should be done expeditiously as much as possible, so that the time that patient will be able to aerosolize the virus will be minimal. In the room, the endoscopy team must be committed. There should be no one going in and out of the room because that's a break in the system. And then don't change the team in the room, even though they're tired 2 to 3 hours already. Then you should decide to stop, but do not change the team in the room. And of course, again, avoid splashing contaminated fluids, such as this example. In your specimen trap, do not overturn the cup. Get the specimen with a forceps to avoid splashing and aerosolizing the virus. Previously, in the early stages of the COVID pandemic, we used to use a lot of acrylic boxes, and a lot of people actually donated them. But these are now no longer in use. So we used to have holes for the anesthesiologist, another hole for endoscopists, and a small hole for people who might put in a suction tube, feeding tube, etc. But recent studies have shown that it offers no advantage to your current PPEs. And we now actually just use them as large face shields when we transport our patients across wards. So you put that whole box there so that patient does not aerosolize the virus. And we no longer use them inside procedure rooms. The fourth challenge is, of course, environmental control. Control of the room, control of the equipment, and control of the staff in this environment. Unfortunately, as most of us, we do not have negative pressure rooms. So what did we do? We just open windows. When you open windows, air exchange increases. Thus, the particles that go into the air do not stay in the air, do not stay in the room. They go out, and the viral load is very minimal. We also did a one-way in, one-way out policy and designated rooms as COVID and non-COVID rooms. But we clean them both thoroughly, even if it's a non-COVID room. So these are examples of designating donning and doffing rooms, again, to decrease cross-contamination. And for the doffing area, we advise that you have it in an area that is well ventilated. And we also designated COVID and non-COVID rooms, again, to decrease cross-contamination. In the COVID endoscopy unit, when you perform your endoscopy, there's only essential equipment inside. The less equipment inside, the less cleaning time, and the less equipment that are contaminated. Minimum of 3, but hopefully that's just the maximum that you put in the endoscopy room, should be in the room. Just 3 people, the endoscopist, the assistant, and an anesthesiologist if you want. One assistant can stay outside of the room to be your runner and only perform the procedure with a highly skilled endoscopist, again, to expedite the procedure. If you have trainees, they may perform only when community health risk level is low and there's adequate PPE reserve. And hopefully, if the patient is just non-COVID. In COVID situations, then you have to think about if you want to still train your trainees. You do terminal cleaning after each procedure. Clean as if it's the end of the day. So that's thorough cleaning if your patient is a COVID patient. And if possible, just clump together all COVID procedures in the afternoon so that, again, it will decrease the risk of cross-contaminating a COVID patient to a non-COVID patient. We also did team rotations, meaning we designated teams and then they were on 2 weeks and then 2 weeks off. A team can be designated to COVID areas, a COVID room, and then another team can be designated to a non-COVID area or non-COVID room, and then they rotate and then they switch. Again, this will facilitate contact tracing and cross-contamination of each staff. One of the most difficult challenges is, of course, cooperation. How can you maintain that your staff, your endoscopists will follow the rules, will follow the system, will follow the protocols? So it's very hard. But endoscopy is not performed only by the endoscopist, it is performed by a team. So we always say in our endoscopy unit that during this time of COVID, we're always in it together. It is just not me. We are a team. Thus, when we made the protocols and the system, we decided most things as a team. It was unanimous decisions. We think of policies that would benefit both patients and the staff equally. And of course, we watch each other's back. That's why there's a buddy system. Team discussion is also very important. All members should be trained on all COVID protocols. So we do regular lectures on what COVID is, what are the updates, and we do even trainings during the pandemic on how to doff, how to don, how to properly clean the scope, etc. All team members are adequately informed about the procedures and patients as well, even before the patient comes into the endoscopy unit. They know the indication and the goal of the procedure. And this ensures that the procedure is completed as efficiently and as safely as possible. Of course, as Benjamin Franklin has said, if you fail to plan, you are planning to fail. So with all of these protocols, systems, and all of these challenges, you have to plan, but you also have to prepare and then practice. After practicing it, you repeat again and practice again until it becomes second nature to you. And with that, ladies and gentlemen, thank you for your attention, and I bid you a good afternoon.
Thank you, Dr. Delusong. May we now call Dr. Delusong and Dr. Doshi. Okay. We have time for a few questions. Okay, and if you have questions, please type it in the chat box so that we can forward it to our speakers. Okay. My first question, Dr. Doshi. Big data would say that conservative management seems to be working for patients with upper GI bleeding, and there might no longer be a need to do upper GI endoscopy on a significant number of these patients. Moving forward, will our guidelines as endoscopies also change once the COVID pandemic is over? Will we change our guidelines to say, oh, we do not need to do endoscopy within 24 hours because basically most of them will get better? What do you think?
No, that's a very interesting question, and it does seem that once COVID is more settled, this might affect our day-to-day practice in terms of managing GI bleeds. I think, of course, for variceal bleeders, for suspected variceal bleeders, the management doesn't change. We continue as. But for patients that seem to be responding to medical management, there is more insight now, I think, in terms of conservative management and how the outcomes are just not significantly different for this group of patients. So, yeah, I mean, I think, we've been probably subconsciously been doing this anyways, but I think it's become more obvious now.
Yeah, thank you. Moving forward, what do you think are the best practices that we can get from our COVID experience?
I think, just the general sort of precautions. I think in Singapore, we've kind of become a little bit complacent, I think. But certainly, I think being more aware of this infection, making sure that we gown up and we protect ourselves and protect our patients that we subsequently scope, because the worst thing to do is to pick up this infection and then to be spreading it to our colleagues or to other patients. So I think the thing that probably sort of stands up is that we need to continue this process of monitoring and protecting ourselves with PPEs and appropriate steps, basically.
Yeah. There's a question here from one of our past presidents. Is there any data to show that the incidence of COVID-19 infection among endoscopies is higher compared to the other subspecialties, given the presumed aerosol generating environment we work in?
So I haven't come across that data. I did look at that. I didn't come across that. I'm not sure if it's sort of well known at the moment.
Yeah, Dr. Delusong, what is your local experience in?
Same thing with Professor Bavesh. I haven't seen an article stating that claim, but I think we just need more time, and then we'll find out soon because we're learning a lot from this COVID.
Yeah. Another question is, do you have experience of aerosol suction during endoscopy procedures? It's actually the same aerosol suction dentists are using for their procedures. Have we come across that before?
So you mean not a negative pressure room, but
not perhaps not the negative pressure room.
I'm not that familiar with it. I'm sorry.
Yeah.
I think Dr. Ona is asking about the suction that you put at the side of the mouth when we do dental procedures. Yeah, it seems theoretically sound, but again, we don't have evidence for it. Yeah.
So again, if you have questions, please feel free to write in the chat box. A practical question for both of you. Do you spray silocaine spray to our patients with upper GI endoscopy?
So
you can go ahead, Bavesh. Yeah.
Thank you. So look, if these are patients that are COVID positive and they absolutely need a scope, they're more often than not in ICU, and they're intubated and they're ventilated. And so in this kind of situation, we're not, obviously there's no need to spray the back of the foot. In my routine practice, we still do, we follow the general advice. We tell patients not to breathe in during the spray because it can induce a severe cough response if you inhale it. So we tell them to hold their breath for about 5 seconds or 10 seconds as we're spraying, and then we spray. But for COVID patients, generally, we haven't been spraying because, as I said, most of them are in ICU, most of them are being ventilated, and so we're not spraying the back of the throat.
Yeah. There's a comment on the use of the aerosol suction, and apparently there's a study in on that, and it seems to work. Maybe we could we can take a look at that study and maybe comment in the future. Another question is, can you comment on using bismuth containing anti-ulcer medication as prophylaxis for COVID patients identified as high risk of bleeding?
Yeah, I saw that study. I think we need a little bit more data on it. That was a single study from Hong Kong. I'd like to see a little bit more data. It's hard to say at the moment. There's a lot of stuff out there, and it's we don't know whether it's going to go down the hydroxychloroquine route or whether it's going to be more sort of mainstay. So at the moment, it's hard to say. I did see that study though.
Yeah. Okay. Thank you. Dr. Delusong, can you comment on perhaps can we do a GI COVID team? Gastroenterologists seeing COVID patients alone.
We actually did that just to make sure that it decreases the contamination of the whole endoscopy team. I think it's the same as what Dr. Bavesh has mentioned. They have a bleed team. So basically, the bleed team is the COVID team. So they go in for a couple of weeks, all of the team, and then they have a break for 2 weeks, and another team takes over. So it takes care of cross-contamination.
Yeah. Okay. I think we have time for just one more question. In admitted patients, when doing RT-PCR prior to endoscopy, do we also require testing for the watchers and the guardian as well?
So let me answer that, Professor Babesh. But I think that's a local question.
Yeah.
Because in our country, resources are very scarce, and we need to like limit all of the expenses that we give our patients. So ideally, we should not do RT-PCR of our outpatient watchers because they don't go into the endoscopy room anyway. They're outside. So basically, just test the patient if you really need to test the patient. And as we've shown through the data, if the community transmission is very high, you may opt just to do a level 4 PPE and not test anymore because almost everybody is infected anyway. If it's intermediate, probably you need to test. And if it's low, then you don't need. Okay.
All right. Thank you. Again, if there are any questions, any more questions, we'll just forward it to Professor Babesh and Professor Delusong. It has been a pleasure moderating our two excellent lecturers on GI bleeding in this new normal. And we know we will have more data in the future, and this thing, our guidelines may still evolve and change in the future. With that, I'd like to thank everyone for attending and have stay on for our next topic. Thank you.
Thank you, Gentry. Thank you, Babesh.
Thank you,
Thank
everyone.
you. Thank you.
Thank you to our moderator, Dr. Gentry D. We will now have our breakout session. For this breakout, we will be having 3 breakout rooms of our minor sponsors, wherein you get to stay for 5 minutes per virtual room. After 5 minutes, you will be transferred to another breakout room. After visiting all 3 rooms, you will automatically be transferred back to the main session. All attendees will now break out into our sponsors' virtual rooms, and our webinar will resume in 15 minutes. Please stand by. We now proceed to the next portion of our webinar. To introduce our next two speakers and to facilitate our Q&A after the lecture is our moderator. He obtained his medical degree from the University of the East, Ramon Magsaysay, and completed fellowship training in gastroenterology at UPPGH Medical Center. He also completed fellowship training in advanced therapeutic endoscopy at the University of Amsterdam Academic Medical Center in Netherlands. He is past chairman of the Council on Malignancy of PSG, past chief of section of gastroenterology at Veterans Memorial Medical Center, and a past president of the Philippine Society of Gastroenterology. Our moderator is Dr. Jaime Ignacio.
Good evening, ladies and gentlemen, and it's a pleasure for me to moderate this next interesting session. Dealing with an unprecedented infectious disease like COVID-19 has radically changed the way we practice medicine. We now have to face various clinical challenges such as new diagnostic testing procedures, novel therapies, and ever-changing criteria for disease recovery. The gastroenterologist is further faced with issues like COVID-19 related GI symptoms and how to consider them and manage them, as well as pre-procedure diagnostic tests. With us tonight are two experts who will clarify for us these important issues. Dr. Edsel Salvaña received his medical degree from the University of the Philippines College of Medicine. He trained in internal medicine at the Medical College of Wisconsin in Milwaukee and did his fellowship in infectious and tropical medicine at the Case Western Reserve University in Cleveland, Ohio. He is currently the director of the Institute of Molecular Biology and Biotechnology at the National Institute of Health, an associate professor of medicine at the Philippine General Hospital, as well as adjunct faculty for global health at the University of Pittsburgh. He is a recipient of a Philippine Outstanding Young Men Award for his work in HIV. He has also been selected as one of the 10 outstanding young persons of the world and a young physician leader of the Inter-Academy Medical Panel of the World Academy of Sciences. He was recently awarded a Senior TED Fellowship in recognition of his work in restoring vaccine confidence and improving science communication to the public. Dr. Frederick T.D. is our gastroenterologist, and he obtained his medical degree from the University of Santo Tomas Faculty of Medicine and Surgery. He underwent residency training in internal medicine as well as a fellowship in gastroenterology, both at the UST Hospital. And he further went on to receive fellowship training in endoscopic ultrasound and advanced therapeutic endoscopy at the Universitäts Krankenhaus Eppendorf in Hamburg, Germany, and in Bhatia General Hospital and Yaslok Hospital Research Center in Mumbai, India. Currently, he is an associate professor at the UST Faculty of Medicine and Surgery and heads the section of gastroenterology at the same institution. He is a member of the board of directors of the Philippine Society of Digestive Endoscopy and a member of the newly formed ad hoc committee for the Philippine College of Gastroenterology. And he is a past president of the Philippine Society of Gastroenterology. With that, may I please call on Dr. Salvaña to begin delivering his talk.
Thank you very much, Dr. Ignacio. Let me just share my slides here. Okay, so it's a pleasure to be here and virtually though. But thank you for the invitation. As you know, my wife is a gastroenterologist, and so is my father-in-law. So I could hardly say, I can't really exactly say no to this, but it is a great honor. So let's talk about this. It's a very broad topic, but I was given several objectives, and Dr. D will actually talk more about pre-op screening. But the objectives that were left to me were whether when to test COVID-19 in patients with GI symptoms, discuss the use or misuse of testing prior to hospital discharge, and discuss misuse of testing for work assumption for both healthcare workers and non-healthcare workers. So just very basic, we know that the disease is called COVID-19, the virus is called SARS-CoV-2, and nCoV is just a temporary name. The clinical presentation is variable. About 10 to 30% of patients will be asymptomatic or paucisymptomatic, where they'll just have 1 or 2 mild symptoms. But the vast majority of patients will have mild disease. 80 to 90% will have upper respiratory tract infection type symptoms, with or without fever. For moderate risk, these are patients who have pneumonia but do not require oxygen. And then severe disease, 5 to 10%. These are people with pneumonia who do need oxygen supplementation. And of course, critical, which is 1 to 5%. These are the patients who need ICU care and ARDS. If we look at the most common symptoms that they find in hospitalized patients, you can see that the most common is really fever, followed by cough, shortness of breath in those with moderate risk to severe disease. But farther down is where you actually see diarrhea in anywhere from 2 to 10% of patients, along with nausea and vomiting. So those are the kinds of GI symptoms that you see. In one paper, actually, they characterized how common isolated GI symptoms were in the absence of respiratory symptoms. And that's a very, very rare. Only about 3% of them will present with an isolated GI symptom. So when somebody comes in with diarrhea and they're not sure if they got exposed to COVID or not, it's probably not going to be COVID. Of course, if they had an exposure, direct contact with a known COVID patient, then that's the time we think about whether we need to test them. But in general, completely isolated GI symptoms shouldn't really prompt someone to test for COVID unless there is a strong exposure history. Of course, you do find digestive symptoms fairly commonly with respiratory symptoms in about 47% of patients. And this includes non-specific ones like anorexia, nausea, in addition to ones that are more explicit like diarrhea. So this is yet another paper that looked at those symptoms, and you can see that really the most common symptoms are diarrhea, as well as hepatic impairment. All the other ones just kind of hang out, some of them with or without respiratory, but more commonly with respiratory symptoms. This is a very busy slide, so I'm not going to go in detail, but what they did was they actually did almost like a meta-analysis of all the different symptoms, and so what proportion of COVID patients had them. When I saw this, I said, wow, these guys are doing something, are really something else. But you can see that with the forest plots, the diamonds are the ones that show what proportion are shown, and these are not, still in the about 20 to 40% range, similar to what we showed. So just to recap, usually patients present along with respiratory symptoms. As we showed, 47% who do have GI symptoms will also have respiratory symptoms, and only 3% will have completely isolated GI symptoms. Again, the most common presentations for COVID-19 are diarrhea and hepatic function impairment. GI symptoms only is rare, but these patients still usually have fever. So if it's diarrhea without fever, even lower on the totem pole. And then in general, you're not likely to test a person with isolated GI symptoms unless they have exposure and also if they have fever. This is just a little bit, the testing for different parts of the GI tract. It's very difficult to figure out whether that's viable virus or it's just virus that gets swallowed. So, it's kind of a mixed bag when they do specific sampling in different parts of the GI tract. For viral RNA, you see it in half and the other half no. So it's very variable, and we don't know if that's viable virus anyway. We can do transcriptomics to see if it's actively replicating. But again, it's very difficult to pinpoint exactly where that's happening. I'm not going to try to explain to you GI people what these findings are, but they have seen some very specific ulcers associated with patients with COVID on endoscopy, and there might be an ischemic component to it, but I'm not going to go there. I'm just showing this picture because it was in one of the papers that I was looking at. So very briefly, let's go through the different kinds of tests, RT-PCR, antibody test, and antigen, which is the newest in our armamentarium. This is a busy slide, but it actually shows you which tests will likely be positive at different points of the disease spectrum. And you can see the red one is where you can actually isolate culturable virus. So that's when you have a person who's actually infectious, as opposed to the blue line where the PCR is, and you can see that even after the patient is no longer infectious, you can still keep detecting viral RNA, but it doesn't necessarily mean they are contagious anymore. Just to show that specifically, there is a pre-infectious period where the viral load is high, where the patient is still infectious because the virus is still quote unquote alive. And then of course, the infectious period, you have PCR positive. But after the infectious period, you will still be positive by PCR for a long time. Precisely because you're detecting viral genetic material that is actually just pieces of the virus that's no longer viable. And so this is the problem with PCR. It's a really lousy test for cure, and you will continue to detect PCR positive virus in patients who are no longer infectious and have completely recovered. So RT-PCR is a test for nucleic acid. It's really best for acute disease. It does not distinguish between infectious virus and viral genetic material remnants. It's very sensitive, but also the type of specimen can affect the specificity. So it is a standard for diagnosis. You need a BSL-2 facility. You need a high level of technical skill and equipment. UPNIH, Gene Expert Test, Sansure, these are all RT-PCR tests. There are some nucleic acid formats like the Abbott Rapid test and the LAMP, which is still in the research stage. The Abbott Rapid, they're actually using it in the United States. We don't have it here because the US took all the supply. The advantages of the RT-PCR, the standard for diagnosis, it'll pick up even pre-symptomatic patients, but it is less sensitive in asymptomatic patients. It is known technology. It's very specific. So a positive is almost always a real positive. And the only time you'd actually have a false positive is maybe if you contaminate your specimens. So the limitations are it's expensive and resource intensive. And even with a nasal swab, you will still miss about 1/3 of COVID-19 positive patients. It's not because of the PCR itself. It's because of the way you collect the specimen and also transport to the laboratory. It's again, a poor test of cure. Doesn't tell you if the patient's recovered because he can shed virus for a long time, for weeks. And it is prone to contamination if you don't know what you're doing. So a positive RT-PCR can be a true positive, or it can be a contaminant. Theoretically, you can actually have inhaled virus that's not enough to infect you. This is what happened probably to that dog in Hong Kong who tested positive and never got COVID. Or it could be residual infection, which is no longer viable and is post-infectious. For negatives, it can be a true negative, or the first 3 days from exposure when you actually get infected with COVID-19, but you are still incubating, 0% will come back positive. So if you test for COVID too early in a patient who has been exposed and is incubating the virus in the first 3 days, that test will almost be uniformly negative. So we actually recommend that for someone who is asymptomatic and was exposed, you wait about 5 days before you test that person if you want to test the person. If you get a poor inadequate specimen, if you don't go all the way to the back, that'll affect the sensitivity. And of course, if the kit fails. Again, the blue line is RT-PCR. So before the patient has frank symptoms, you may be able to detect it 1 to 2 days before, and then for a long time after the patient gets better. For antibody tests, there's 3 formats: ELISA, ECLIA, or CLIA, lateral flow assays. PRNT is for research only and uses live virus. The tests are IgM, IgG. There's even an IgA, or all of them. it's best to test after at least 7 days of symptoms. So these are patients who are already recovering because it takes a while for you to produce antibody. So CLIA, ELISA, these are lab-based. These are fairly accurate, much better than a rapid test in terms of accuracy and particularly specificity. You get a lot of false positives with rapid antibody tests as well. This takes about 1 to 2 days. They're a little more expensive than the rapid tests. The rapid tests, on the other hand, have very variable sensitivity. There are some really bad rapid tests. That's why we call them rats. We call them dirty rats. So in general, we're not very fond of rapid tests because of the low sensitivity and specificity vis-a-vis CLIA and ELISA, and also the timing of the testing. So the advantage is if somebody's recovered already, you can still pick up that infection with an antibody, because antibody can hang out for several weeks. Up to about 35 days, and it starts to drop. It is less resource intensive, although the CLIAs are actually fairly expensive, and you still need a laboratory, although the rapid tests are really easy to use. And then we don't know if the antibody is neutralizing antibody, so it doesn't necessarily correlate with immunity, and we know that some people have been reinfected as well. So we don't know what titers of antibodies are actually protective. So even if you're IgG positive, I'd still wear that mask and keep physical distance, because we don't know who's going to get reinfected. Although most likely it's fairly a rare thing, but things are evolving, so we'll see what happens. Antibody tests are almost completely useless when you're looking at asymptomatics, because they're not, they're not producing antibody yet. In some asymptomatics and mild disease, they never produce antibody. So there's really a lot of false negatives. And again, IgG does not necessarily mean immunity. And if for rapid antibody tests that have low specificity, that is prone to false positives that cross-react with seasonal coronaviruses and other viruses. So a positive antibody test is either a true positive, or it's cross-reacting with something else, either the IgM or the IgG, or it's a defective kit. For negative, it's true negative, or it's too early. Again, almost completely useless in the first 7 days of symptoms. Low titers or no immunity was generated, and this does happen for patients who have mild or who have mild symptoms or are asymptomatic. Interestingly, the level of antibody seems to correlate with the severity of disease, because if you have a lot of immune activation, then you should produce a lot of antibodies. Of course, there are exceptions like immunocompromised patients. And of course, if there's kit failure. And those are the dotted lines. Notice that IgM and IgG almost show up at the same time. This is not like with dengue where IgM goes first. And they can hang out for a long time, both of them. So IgM, IgG at the same time doesn't mean you haven't recovered or anything like that. It means nothing. But an isolated IgM does make people nervous, and so we tend to test those people if ever we get somebody like that. There's a couple of meta-analyses that looked at the bottom line of this study is that lateral flow assays, which are the rapid antibody tests, are not recommended for routine use at all. And a Cochrane review also showed that the sensitivity in the first 7 days is less than 30%, and then it only starts to become useful maybe 8 to 14 days, best around 21 to 35 days, and then it starts to drop off as well. So rapid antibody tests, not very good. The CLIAs and the ELISAs, you can use them for people who have had symptoms for at least 15 to 21 or more days. To make that diagnosis. But again, it's not very useful for acute disease. And then lastly, antigen looks for a piece of the virus, but in contrast to RT-PCR, it doesn't amplify the genetic material. So you need about 10 times as much virus to be detected compared to RT-PCR. But the nice thing about it is it actually correlates with infectivity, because when you have low viral titers that can still be detected by RT-PCR, chances are if it's very low, if the CT value is above 30, which correlates to a very low viral load, most patients are no longer infectious. And so actually antigen correlates much better with infectivity rather than PCR. So there is a faster turnaround time than RT-PCR. It picks up contagious patients Of course, if it's an early patient who's still going to increase their viral load, then it can completely miss that. And that's part of the problem with using antigen too early. You don't need a BSL-2. This is very specific. Some are point of care. Some need a machine, but they don't need a sophisticated lab as RT-PCR, although you still need to use the PPE because this is still a swab. So it's less sensitive. It's about 80% as sensitive compared to an RT-PCR. For asymptomatics, it's much less because their viral loads are very low. Again, you need PPE for swabbing. There's variable sensitivity for the different kits right now, and that's still being validated. So it can be a true positive. And in fact, a positive antigen will be considered a positive test. You don't need to confirm it with RT-PCR. It can also be contamination, but this is less likely compared to RT-PCR. I mean, you'd need a lot more virus to contaminate rather compared to RT-PCR. Or you could have a defective kit, or the residual virus is not likely, unlike with PCR, but it can still happen. Some people do have residual virus for a longer period of time. Negative antigen is either a true negative, and then it is more susceptible to false negatives because it's too early. In fact, the antigen becomes positive is best used in patients with symptoms for the first 7 days. Or you got a poor inadequate specimen, or there's kit failure. And the antigen most correlates with the red line here where you actually do have infectious virus. So there's no good test for asymptomatic carriers. At best, your RT-PCR will probably detect, at best, your RT-PCR in symptomatics on the third day of like 80% of patients. For asymptomatics, it's much lower than that, maybe 20, 30% if you're lucky. And so what happens is if you do a blanket screening of everyone who's asymptomatic, even if there are people who are positive, you'll probably only get 1/3 of them. But RT-PCR is better than antigen. Antibody test is almost completely useless in those situations. The antibody tests can capture people who recently had disease and are already negative by RT-PCR. Usually they're not contagious anymore. So these are more epidemiologic use rather than looking for patients who have active disease. But the biggest priority, knowing that our tests are not great at detecting asymptomatic carriers, is that we should always treat everyone as potentially contagious, and everyone, even those who have recovered from COVID, as still potentially, they can still get infected. So as long as everybody does the minimum health standards all the time, then we can minimize the risk of transmission. This just shows that whatever test you do in patients who are screening during the incubation or asymptomatic phase, none of our tests are any good for that. However, if we're talking about, and I know Dr. D will talk about screening, there might be some utility to that because you even just one person that you intubate and fuse all that stuff all over, there might be some utility. Again, it's a value call, and that's going to be discussed much more later. So best use for diagnosis, RT-PCR for suspected COVID-19 patients with symptoms and for those who are exposed, who actually do have a high pretest probability. But if they're asymptomatic, say healthcare workers were exposed and they didn't use proper PPE, you should test them at least 5 days from the last exposure, quarantining them during that time while waiting for 5 days. Antigen can supplement RT-PCR if it's not available, especially for symptomatic and close contacts. A positive test is real, and it can supplement, but right now it doesn't. It's even less sensitive than RT-PCR when you're looking at people who don't have any symptoms. Antibody tests are really best for diagnosing past disease, to complement diagnosis, serosurveys, testing for convalescent serum donation. We don't recommend rats anymore. CLIA or ELISA is the best, but in a pinch, you can look for a rat that has a better characteristic. I'm not gonna dwell on this. I posted this on Facebook if you really want to see the whole thing. This just shows you that there is no perfect test. Even at the best time to test, on the 8th day of exposure, 3 days of symptoms, at best, your RT-PCR will be 80% positive. And most other times, it's going to be much lower than that. An antibody in the first 5 days is just completely useless. Okay, so testing for discharge of patients is no longer required precisely because the virus can continue to be detected by RT-PCR up to 8 weeks. So that's kind of a useless thing. Masusugatan na lang yung pasyente mo sa ilong niya kasi kakaulit mo. It's very, very expensive. Culture studies have shown that the virus is typically no longer culturable and therefore no longer infectious after the 10th day. It may be longer for severe disease or immunocompromised, but for mild to moderate in general, 10 days from the start of symptoms, patients should not be contagious anymore and can discontinue isolation, provided that they have had at least 3 days where they have been symptom-free. Just again to remind us what's happening, the red line is where people are infectious and the PCR is going to be positive for a long time. And also, again, the pre-infectious versus the post-infectious is an important point. So returning to work for known positive. For non-healthcare workers, it's just if you're asymptomatic, 10 days from the positive test, you can go. There's no risk. If mild to moderate symptoms, complete the isolation for 10 days plus the 3 days, you're okay. For severe, it's 21 days from the start of symptoms plus 3 days without symptoms. No need to repeat RT-PCR unless immunocompromised, but you still need to be cleared by a physician or your occupational health provider. For healthcare workers, it's different because each hospital has its own guidelines in terms of whether you need 1 or 2 swabs that are negative, because there is theoretically a residual transmission risk to patients. So for healthcare workers and immunocompromised, sometimes we may still do a test-based strategy, but that really depends on the symptoms. You know, what you can do is you can do this case to case, talk to IDS infection control for individualized recommendations. Sometimes we'll check IgG titers. It makes us feel better that the patient's really recovered. But this is, again, not everybody develops IgG. So can I get COVID more than once? There's increasing reports of reinfection with genetically distinct viruses, but we know that most people do develop some sort of immunity. Majority have antibodies that so far we know in the Iceland cohorts last up to 4 months. Some don't develop antibodies at all. So there's no clear consensus on degree or duration of immunity for now. And that's why they say that even if you've had it before, you might actually still benefit from getting the vaccine when we get an effective vaccine, because your immunity might not be long lasting. And then finally, for the just for workplace safety, understanding that our PPE is actually our last line of defense. So we really want to make sure that like for work, if you can work from home, even better, that eliminates the risk. Shifts so that there are less people there at the same time. Good ventilation, acrylic barriers. I know a lot of doctors also have acrylic barriers in their clinics. Symptom screen, temperature check, isolation rooms, masks, face shields, and physical distance will decrease the risk. Now, just to show you what is the most important interventions in terms of decreasing your overall risk for COVID-19. If you do random mass testing, I'm not talking about proper testing. Proper testing is important for people who have symptoms, who have exposure when you're doing contact tracing. But the idea of randomly testing everybody, like 5% of the population per week, that's like 5 million tests, will only result in a reduction of transmission by 2%. So that's a completely useless exercise. Sayang ang pera. It's better to make sure everyone wears a mask, has face shield, has physical distance, and then the daily symptom screen, because people who are symptomatic are 10 to 20 times more contagious than asymptomatic people. So just getting out the symptomatic people already decreases your risk for transmission by 80 to 90%. And yung tinitest mo na 10%, 1/3 lang dun sa mga asymptomatics ang mapipick up mo. So it's not really efficient in that sense. Now, for people who are sick, if you do home isolation, this impacts transmission by 29%. Facility isolation, 35%. Entire household plus home isolation, 37%. Contact tracing plus home isolation plus entire household quarantine, 64%. Pag pinagsama-sama mo yan, it gets close to 100%. So we need all those interventions, or what they call the Swiss cheese strategy. Basta hindi mag-line up yung holes, ma-protect ka pa rin. So how do you protect yourself? Wash your hands, mask, face shield, physical distance, avoid crowds, stay home if you're sick, update yourself on the latest developments, don't spread fake news, and vaccinate with influenza and pneumococcal, not because this has any effect on COVID-19, but because actually we do have people who have been co-infected with influenza and also strep pneumonia, and they've actually had worse outcomes. So in summary, COVID-19 can affect the GI tract. GI symptoms are usually found with respiratory symptoms. Only 3% have isolated GI symptoms, and usually they have fever. So testing is not a panacea, but can be effective when used properly. Understand the proper use of tests. Time-based clearance is the rule for patients who've already had it. Workplace safety is important, more so than testing. Testing can help, but you have to use testing properly in patients who are symptomatic or who have exposure. And you can also think about like for highly exposed like healthcare workers. But in general, we need to use all these interventions in order to continue to keep our numbers low so that our healthcare system remains viable until we get to a point where we get an effective and safe vaccine. Thank you very much.
Okay, can you see my slides? Dr. Ignacio?
Yes.
Okay, so
go ahead, please.
Good evening, everyone. I will begin by congratulating the Philippine Society of Gastroenterology, of course, ably headed by the Board of Directors, together with the organizing committee, for a very successful virtual mid-year conference. Now, I was given a very controversial topic. In fact, even though we keep on talking that there's no question that for patients who are symptomatic, we really need to do testing. And the title that was given to me initially was actually different from this one. And I'm very happy that the organizing committee agreed that I would change the topic to being direct to the point and going to patients who are asymptomatic. I'm sure that when we talk about COVID swab testing, there's really a lot of issue on this. When we see, for example, this question can be answered dichotomously. However, the question to be answered is really far from being very easy. I'm sure that when we talk about this, I would incite a lot of arguments, pros and cons based on doing swab testing prior to doing procedure. However, I don't want to be placed in a rabbit hole, and I will not argue or disagree with anyone, but rather I will try to answer this to the best of my ability, looking at, of course, the evidences that we have at the moment. Likewise, I know also that some of the attendees are not really gastroenterologists. However, I would like to use endoscopy as an example, probably because I am more familiar with endoscopy, but I'm sure some of the principles that I will be sharing here would also be useful depending on your area of work. Now, when we talk about decision-making, I mean to say we want to choose one or the another, I'm sure it can be affected by a lot of things. We look at alternatives. We also look at the uncertainty of the problem. Are the consequences high risk? Are there interpersonal issues? Complexity of the problem? Of course, apart from that, we know cognitive biases, psychological biases, knowledge and past experiences. And this may probably define on what we're supposed to do. Should we pursue testing or should we avoid or do not pursue testing? Now, let me borrow this statement by Michelle Obama, that you cannot make decisions based on fear and the possibility of what might happen. Now, we know for a fact that healthcare workers are one of the job that has the highest risk of getting coronavirus. This is because of person-to-person by respiratory secretions or salivary droplets. Also, the aerosol generated by medical procedures like intubation, like bronchoscopy, and of course, endoscopy, wherein we're actually doing. Contact with body fluid and contact with the contaminated surroundings. So, initially, when this all started, when this all broke loose in March, there were actually a lot of recommendations. But the screening strategy was not reported by a lot of these organizations, even the AGA, the American Gastroenterology Association. Questionnaire was being implemented by some of our friends or from our neighbors, and also some from other countries. And questionnaire together with body temperature are also advised by some. During that time, the Philippine Society of Digestive Endoscopy and the Chinese Society of Digestive Endoscopy were recommending to use RT-PCR prior to endoscopic procedures. Although some of the other guidelines or some of the other statements, recommendation were not saying so. They were not explicitly stated that RT-PCR should be done. This would include the ESGE and this one from the Japan Gastroenterological Endoscopy Society and even the AGA Institute Rapid Recommendation for Gastrointestinal Procedures. However, it is clear from a few of the recommendations like the APSDE COVID statements and the one from Italy that for symptomatic patients, there's no question that RT-PCR should be performed. And these are the possible reasons for the differences in recommendations. We know that because this is a pandemic, we are scared of this, and everybody wants to go to the side of caution. Number two, initially there were actually limited testing sites, and therefore point of care is really not possible. But right now, I'm hearing that some institutions are offering very rapid result of this COVID-19 test, RT-PCR, in a matter of 1 to 2 hours, we can already get the result. So a point of care may be possible. If you take a long time for the test to RT-PCR to be done until you do the procedure, in between, the patient could get infected. And the delay in the results, validity according to most of the recommendations, is only 48 to 72 hours. Now, the question of accuracy of the test, and this was aptly explained by Edsel a while ago, and also the adequacy of PPEs. We were actually scavenging for PPEs initially, but as we go to the new normal, then we know that we can actually have more PPEs and try to fix the problem. And finally, the lack of data. Clearly, there are a lot of studies looking at COVID-19, but the data, a lot of the answers that we need aren't really answered by this. So, some guidelines suggested that screening behavior might change. In fact, I think the guidelines should be constantly revised every 6 months because we have new data coming out. In fact, we know that their behavior would be depending on the availability and accuracy of the rapid testing against the community prevalence of COVID-19. So I would like to borrow this word because I heard from Dr. Dance during the PCP meeting. He was mentioning about a living systematic review. I mean to say it is real time. I think guidelines has to be real time as well, and probably living guidelines would be a better one to follow. So why do we test for COVID-19? Maybe if I'm an epidemiologist, I just want to know. I want to know how many patients are infected with COVID-19. Of course, practically, I'm an endoscopist. I want to risk stratify according to what level of PPE one should be using, or which type of room should I use. If the patient is COVID-19 positive, of course, I would prefer a negative pressure room, or order of the endoscopy wherein we can perform. If patient is COVID negative, then you can do the patient first. However, if it's positive, then I would probably perform the patient last. And of course, probably for some, I mean, it could be a security blanket telling us that, patient is COVID-19 negative and therefore we are kind of safe. However, from a practical standpoint, if there is truly community transmission, then as mentioned a while ago by some of the speakers, all individuals must be assumed to be potentially infectious and contagious. Then pre-testing COVID-19 becomes less important because it will not change the way we stratify patients. Number two, if you agree with me that all patients, you will use a PPE level 4 on all patients, regardless. Therefore, the result of COVID-19 will not influence you to be able to tell your patients that I will use a less amount of PPE for this purpose. Now, some would say that testing may not really be so harmful, but probably there's downsides of pre-testing strategy. Like, because of the limited number of testing sites, there could be a delay in the results for those who truly deserves it or requires it, patients who are symptomatic. The psychological harm of testing positive for those who are asymptomatic, that you will be put in an isolation, and this can be perceptible to some. Now, we are talking about the veracity of the test is a possible issue. Some are saying they would just go to a place near Manila and they could have the test printed out. You're also increasing the exposure of this individual because when they are going to have themselves tested, they have to go to the hospital. Likewise, we know that our nation is a resource-limited country, and therefore this is an added expense. This is an added expense with an additional burden of economic lockdown due to the pandemic. And more importantly, there's a tendency to be complacent. This is also what was mentioned by Bhavesh a while ago. He was talking about complacency because if you think the patient is tested negative, then you may be complacent and saying maybe the patient is actually safe. Now, let me go over with you some of the factors that may influence your consideration for pre-testing strategy. Let's say, for example, how many are infected, the risk of getting infected, adequacy of PPEs, effectiveness of PPEs, availability of tests, and the accuracy of tests. So let me go over with you the number of infected and risk of getting infected in the country. Now, this is a 2-week data from September 6 to 19. What you will see here is 48,890 cases all across the country. So this would include symptomatic and asymptomatic individual. So I'd like to know the asymptomatic. To be able to get this, we multiply it by a factor of 5 or 10. So I said on the safe side, I would multiply it by 10. So during that time, probably asymptomatic would account to about almost 500,000, which would be equivalent to about 0.4% of the population. Likewise, if I'm going to look at, for example, National Capital Region only, it's about 11,579. So multiply it by 10, considering there are 15 million people living in the metro, so it's about 0.72%. So what I'm just trying to drive here is that the number of asymptomatic would depend on the number of positive tests in your own locality. This is a better way of testing it. Of course, the report says positivity rate of 10.6%. As I mentioned, this would include symptomatic and asymptomatic, and this did not specify these patients. Now, can COVID-19 really transmit this in the GI endoscopy? Of course, potentially it is yes. But let's look at some of the data. There's really a low risk of COVID-19 transmission in GI endoscopy. In this study by Alessandro Rapici, which is the group wherein they were the first one to look at COVID-19 transmission in endoscopy, 851 patients from January 27 to March 13 had endoscopy, received follow-up call after 2 weeks. Almost 95% responded. Of those patients, only 0.5% got infected, and none of these patients required hospitalization. But the date was before donning proper PPEs. This was January 27 to March 13. Doctors were not really doing the complete donning of PPEs. Now let's look at healthcare workers. Same author, 41 centers, 968 healthcare workers, including doctors, nurses, and personnel. 42 were tested positive, about 4.3% during the same time frame. Hospitalization, 0.6%, no ICU, 8 days. And also remember that 86% of them occurred before the introduction of safety measures. So the number of affected is quite big, maybe intermediate when you look at the prevalence. The risk of getting infected may be low. Now, the next thing that we look at, do we trust our PPE and the adequacy of PPEs? So to be able to answer this, you know, these are the guidelines. We need face shields, goggles, N95 respirator, isolation gown with an AMI level 3 and disposable gloves. These are the recommendations for patients with confirmed novel coronavirus. However, for those without, for general patients, AAMI level gown, respirator, and all of this. So basically, these are the recommendations. Now, I'd like to share with you this journal by AGA looking at the safety of the PPEs that what we are using right now. So to compare N95 mask versus no PPE, you will get an odds risk of 0.12. Meaning to say, we are protected about 88% of the time. So N95 is truly useful, and this would translate actually to 302 fewer infected patients or transmission per 1,000 cases. Now, if you'd like to compare N95 mask versus that of surgical mask, you will get an odds ratio of 0.86, and therefore this would translate only to 7 fewer per 1,000. So not so much anymore. The difference between N95 versus surgical mask is not so much. So by another study, 0.78, and this would odds ratio, and this would translate to 9 fewer per 1,000. But look, these are patients during the SARS infection and viral respiratory infection. So we don't know. There could be indirect. The result might not be the same for patients with COVID-19. Okay, and remember also that these studies, when they were performed, they were tested for aerosolizing procedures, which is clear, which are endotracheal intubation and that of bronchoscopy. Now, no question, double gloves is better than single gloves as compared as seen from this study. You will see here that from this report, the relative risk of getting infection for double gloves is 65% lower as compared to those individuals who are only using single gloves. And this would translate to about 500 fewer transmission per 1,000 cases. So clearly, double gloves is important. How about negative pressure room? As much as we want all our endoscopy unit to be negative pressure room, but clearly some of our units are already old, the building, and you cannot just create a negative pressure room. In fact, even the recommendation coming from the AGA that in healthcare workers performing any GI procedure with known or presumptive COVID-19, they suggest the use of negative pressure room. Suggest actually is the word, over regular endoscopy room when available. Okay, so now, how about the physical distancing, face mask, eye protection to prevent person-to-person transmission? This is a systematic review and meta-analysis. And remember that these are all observational studies and there's no randomized controlled trial looking at this. So the grade summary, the further you are from one individual to another, the better. Face mask versus no face mask, yes, it is better to have a face mask, and the difference, absolute difference, is about 15%. Eye protection, no eye protection versus eye protection, another 10% additional protection rate, protection given to you from getting infected. Now, if you look at this, I'll go over with you because this is COVID-19 using this. There's actually no infection related to when you use this face shield and face mask. No? Face shield and together with these goggles, there's no infection actually, no eye protection. But when you look at MERS and SARS, of course, clearly in favor of having your eyes protected and versus that without your eyes protected. Now let's look at the hazmat suits that we are almost always using during endoscopy, during our endoscopy. Does this truly work? Can this prevent? Unfortunately, my slide is truly empty. That is because we don't have data looking at the use of hazmat suits to protect ourselves from COVID-19. I really don't know whether if you get this will go over to your skin. But clearly, if we can use something that we can just leave behind the hospital for disinfection, probably it would suffice because we don't get infected because it probably doesn't go through our skin, and also it doesn't go to our work clothes. If you use the clothes from the hospital, probably it's a lot safer. So another thing that we have to look into would be the availability of tests and the accuracy of tests. Now let's look at the accredited testing centers in the Philippines. As of October 2020, the Philippines have looking at about 110 million population. There are 143 accredited testing centers according to the DOH. And if you like the ratio, one testing center into up to 770,000 population. That's quite a lot. So this may not be enough. I don't really understand this cartridge-based PCR, but it mentioned that about 24% of the testing centers uses a cartridge-based PCR. So finally, I would go over with you because I like this study so much, this recommendation by AGA. It's not really a study, but rather a review by AGA on the testing on the use of pre-procedure SARS-CoV-2 testing and endoscopy. Now, if you look at this forest plot, no question, the sensitivity and specificity of RT-PCR is quite high. 93% specificity, 97, 98%. But when you look at this, all of these patients were symptomatic patients. So we are talking about asymptomatic patients. And therefore, when we talk about asymptomatic patients, we have to look at the prevalence of the infection in the general community. Therefore, pretest probability, if it's very low, then the possibility of false positive tests can be high. If the pretest probability is high, maybe more than 2% of the population, then as mentioned by some of the speakers, we don't really need to test anymore because all we have to do is use a level 4 PPE. But the question arises, what if the patient is intermediate, and in intermediate, what do we do? And therefore, if you look at the guidelines according to the AGA for SARS-CoV infection wherein it is low, the AGA suggests implementing a pre-testing strategy. In fact, the remarks is that in low prevalence settings, a pre-testing strategy may not be informative for triage due to the high number of false positives. Thus, PPE availability may drive decision-making. If you have enough PPE, then you can do your procedure. If PPE is available, the majority of endoscopists, this is a personal choice, may reasonably select to use N95 respirators or PAPRs. However, a small minority with a low risk aversion may really want testing. But in general, if it is low, you may not do it anymore. For a small number of centers in high prevalence where it's truly hotspots endoscopy, so you may reserve this for time-sensitive procedures, and the use of N95 respirators or PAPRs for all procedures is actually recommended. So, in high prevalence areas, pre-testing strategy may not be informative for decision about PPE, and because of unacceptable numbers of false negatives, therefore, PPE availability may drive decision making. In N95, if N95 respirators or PAPRs are available, this may be used for both for the upper and lower endoscopies. And when we talk about hotspots, it is defined by a surge in the COVID-19 cases with an acute burden for hospital capacity. In hotspots, the assumption of outpatient endoscopy may really depend on the availability of PPE. So their recommendations were based actually on the adequacy of PPEs. So for most endoscopy centers wherein the prevalence is in the middle, the AGA suggests implementing a pre-testing strategy using information about the prevalence and test performance in combination with considerations about the benefit and downsides of the strategy. So let's look at this. So the overall consideration, regardless of the testing setting, if it is intermediate, you may say that testing may provide reassurance to patients that all patients in the endoscopy center are COVID negative, but we know it is not really true. Cons, patient burden of testing logistics, particularly given low availability and limit testing sites, provider burden of testing logistics. And this is actually a burden because you need to increase the number of testing. So therefore, probably in intermediate prevalence area, maybe it's up to you whether you really want to do some more testing or not. But their final recommendation, if you look at this crosshair, dividing this picture here into 4 quadrants, you will see here that in the north part, abundant PPE; in the south, limited PPE; in the east, abundant testing capacity; in the west, limited testing capacity. And if you look at the left upper quadrant, regardless of prevalence, they are suggesting not to pursue testing strategy and just wear the highest level of PPE because you have abundant PPE. If you have abundant PPE and abundant testing capacity, whether low prevalence or high prevalence, because of the high false positive and high false negative, then just wear highest level PPE and do not pursue testing. If you go down south and you're here, limited testing capacity, limited PPE, they are still recommending not to pursue testing strategy because of high false positive. You consider wearing surgical masks for lower endoscopy and N95 for upper endoscopy because we assume upper endoscopy is riskier as compared to lower endoscopy. High prevalence areas, hotspots, do not pursue testing strategy and wear highest level PPE. But because you have limited PPE, you only perform endoscopy for time-sensitive procedures. Now, on the right side here, low prevalence area and high prevalence area, same story. They do not advise us to pursue testing strategy because it will not change the way we are using our PPE. So if you'd like to go over your locality and check how many number of patients are asymptomatic or positive, for you to know whether you are in the low, intermediate, or hotspots, then you may want to go to this website. This is from the AGA. So all you need to input is the prevalence of asymptomatic population in 2 weeks' time, adjust for asymptomatic population by multiplying 10, and the population census in the locality, and automatically it will compute it for you, and this would be the estimated prevalence of asymptomatic population. So a rational decision-making process starts with identifying the problem, followed by establishing decision criteria. Then we weigh it, which one weighs more. Do we look at the science more, or are we looking at our personal experience more, or some other things, decision making factors? We generate alternatives. What can we do? And of course, we evaluate them, whether it is helpful. And finally, we select the best alternatives. So this is my own recommendation, my personal recommendation, looking at it. In patients, practically, in patients with COVID-19 who are asymptomatic requiring endoscopy, and they need endoscopy because they are symptomatic for GI diseases, we look at whether there's adequate PPE. If there's limited PPE, we pursue swabbing. The reason for this is that if the swab is negative, then we use a level 3 PPE. Now, if the patient is positive for the swab, then we use a level 4 PPE. So this would influence the level of PPE that we're going to use. If the local prevalence is less than 0.5 or greater than 2%, then swab may be unnecessary, as I was explaining a while ago. But for the intermediate, it depends on your risk aversion. How high are you willing to risk it among this individual? But remember also that a negative test may not really mean the patient is truly negative. So that is my own personal, recommendation. However, I know that everyone has the right to make his own decisions, and none has the right to force his decision on others. And the final verdict is actually up to you. With this, I end my talk, and I thank you for your attention.
Thank you very much, gentlemen, for your very interesting talks. And I'm sure this generated a lot of questions from our audience. And I can see quite a bunch of questions addressed to both of you at the chat box. And let me start off with a question for Dr. Salbanya. Please comment on the use of rapid test. She's probably referring to the RAT, to the rapid antibody test, as a requirement for hiring employees or return to work clearance.
Yeah, that's completely inappropriate. I mean, the only test that we should be doing for returning employees is a symptom screen, and whether they've had any sick illnesses in the last 14 days. Precisely because the point is the rats are not going to detect anyone who is incubating. And if they're symptomatic, then they should get an RT-PCR. And if you're asymptomatic and your rat is positive, you're probably not contagious anymore. So it's completely useless in that sense. Pag mag-false positive pa, ma-isolate ka nang hindi kailangan. So it can even be harmful in that sense. So symptom screen is the best, and make sure everybody wears minimum health standards practices if that will minimize the risk.
Thank you. This is for Dr. Salbanya, and probably to some extent Dr. D as well. Based on your lecture for aerosol generating procedures like endoscopic procedures for asymptomatic patients, there will be no benefit doing an RT-PCR prior to their endoscopic procedure.
Well, there is a benefit, and as Dr. D showed, it really all depends on the pretest probability, because yung risk talaga na may makakalusot I mean, if it's in Batanes, I don't think you need to test. Wala namang COVID doon. Pero in a place, say, where there is ongoing community transmission, then you have the option either you make sure you protect yourself or you test or you do both. The biggest problem, I completely understand the numbers in terms of risk and the problem lang talaga with COVID is yung kappa niya, which is the how many people among the infectious actually transmit. It's very heterogeneous. 70% of people with COVID will not transmit to anybody else. The 30% are the super spreaders. So the reason why we do testing, even if we know that it is it's not very good for high risk transmission procedures that are aerosol generating, is that even one person can infect everybody in the operating room. And so if you can prevent that, kasi we're talking about a room full of healthcare workers. So even if you only get 1/3 of the asymptomatics, from a value judgment standpoint, sa akin, that would be worth it. Kasi I don't want to expose the people in the room. But at the same time, I always say, use level 3 at least. Kasi yun yung point kung makalusot yung 2/3 na kahit tinest mo, nag-negative sila sa RT-PCR, kinlear ko pa rin sila, there's still that risk. So always assume that aerosol generating procedures can infect you. So level 3, kung confirmed, as has been mentioned, level 4 is appropriate.
Yes.
Okay. Derek, can you anything to add?
Yes, agree. I really don't like getting infected and also transmitting it to other healthcare workers. But all I'm saying is that if you have level 4 PPEs and you're using it, I think the recommendation a while ago by KITS on how to reduce the probability of transmission, if you can do it, then it should be enough. It should be enough. Because as I showed you a while ago, all the face mask, the face shield that we have are really protective. And as mentioned by Edsel, in my opinion, he said that asymptomatic individuals a while ago, and the asymptomatic individuals to transmit this virus is very low as compared to those individuals who are symptomatic and with a lot of these viral particles in their system.
Okay, for Dr. Salvania again, and again, Derek, you can also give in your 5 cents worth. When do you think, can you comment on the use of HEPA filters in the clinical setting? In our for our purposes tonight, probably in the endoscopy room or in the room of the patient?
Yeah, so the HEPA filters are useful for getting the particles that get aerosolized out of the air. Most transmission is still droplet. So actually very brief lang yung pag sa air tapos babagsak din yan. Pero of course, if you're doing aerosolizing procedures, lalo na with endoscopy, they can stay up there longer. And so the HEPA filters along with air exchange devices are very important kasi otherwise you'll have to wait a long time before the room is safe to use again. So it can help. Pero kasi, like in clinic naman, kung hindi ka mag-PPE pero may HEPA filter ka, pag may bumahing sa mukha mo, you're gonna get infected kahit ilang HEPA filters pa yung laman nun. So they are complementary to each other. It decreases the risk of the virus staying in the room for a long time. But again, it's one of the things that we do aside from the mask and the face shield.
Yeah,
Derek?
I agree that HEPA filter, if you have it, then it provides an additional barrier for you to get infected. You also, in your unit, if you have windows, I would prefer it to be open. So in some endoscopy centers, especially like in the hospital where I work, there are windows. So we keep them open during the procedure. Turn the air conditioning off and open the windows. It's kind of warm and hot, really, but it's still because we're using PPEs and the layers of clothing that we have. But it's a thing that we have just to accept during this time of pandemic.
While we're there, can you discuss also UV filters? Any advantage of using UV filters in the endoscopy room or anywhere?
Yeah, so again, these are just ancillary measures. And what they do is basically the main way that you transmit pa rin is still droplet. And so masks are the ones that will make the most. Pero yung UV kasi, it can sterilize surfaces. Pero remember that if the droplet lands on a surface, you still need to get that droplet into your eye, nose, or mouth. So, it's much lower risk. If it makes you feel better, then go ahead, go for it.
Yes, yes. It makes you feel better, of course.
This is a question from me. Since COVID-19 is a respiratory illness, then obviously the main symptoms are respiratory in nature. If you have GI symptoms, does that imply that you have had a large dose of viral inoculum, that it got into your GI system and caused GI symptoms?
I don't think anybody knows the answer to that po. I think that some of it may be more of the complications because we know that there's clotting issues with COVID. Baka nagkaroon ng, my wife said nga yung ulcers might look a little bit ischemic. So those might be because of the clotting issues rather than a direct effect of the virus. We know the virus has direct effects on the lungs and also on the heart. So GI, it's less clear because a lot of the virus, half of the time you're not able to culture viruses, so it might not even be active there anymore.
Can you get it from colonoscopies when you get some colonic contents into you?
Yeah, that's very controversial in terms of whether viable yung virus na nasa gut. It's probably less likely to be viable. But of course, if you're doing an aerosolizing procedure, madami yun eh. And so I would err on the side of caution because it's flying all over the place.
Dr. Jim?
Yeah, Derek.
Yeah, I had a chance to review on this earlier on, sometime April. And there were some studies looking at the relationship of GI symptom and the severity of COVID. You may be partially correct, and also nobody really knows. And Edsel is also correct, saying that probably the tumor burden, the viral burden as well. Because if you have a lot of virus that get swallowed, and the GI tract is full of ACE inhibitor, so probably there are some data to show that the more severe the COVID pneumonia is, the greater the chance that we will have GI symptoms as well. That's one. Number two, on the topic of the if you can get infected in the colon, yes, the first studies were looking at RT-PCR and they were saying these are just nucleic acid and not really the live virus. However, there was a group actually which biopsied the rectal area. They biopsied and cultured, and a few were positive for virus. And therefore, these are not only nucleic acid because they grew. And therefore, there could be really live virus there in the colon, possibly. However, dahil nga, it's in the distal part.
We know very little, right? Okay. Let's
all reports, Dr. Jim. These are reports lang. These are not really confirmed. In fact, they also mentioned that this was unpublished.
Yeah, understood. Vaccine, is it coming?
We'll see. Madami naman tayong there's like I think 12 in late phase clinical trials. There's 42 in clinical trials. There's over 100 in preclinicals. One of them is bound to work, but the other thing is that the expected efficacy for the first generation vaccines will only be about 50 to 70%. It's not like going to be the measles vaccine at 95%. So while it will be a big help as you roll it out, we're still going to have to keep those masks on. Matagal pa po ito. We'll probably see the first phase 3 results that are interpretable by the end of November po.
Okay, there's a lengthy question here. Radiology department requiring RT-PCR for patients undergoing liver biopsy. Have patient positive for a month already, was given clearance from the infectious disease, but she has to perform a liver biopsy for some reason, and the patient will still be treated as a COVID patient if the biopsy will be performed, and that will entail cost. So how do you go about this? I'm not exactly sure if you got that question. Did you get the gist of the question?
Yeah, I did.
Or just wait
yeah.
8 weeks? What if the PCR remains positive?
Yeah, so that's a real problem with testing-based approaches. Unfortunately, as has always been said, if the person who is doing the biopsy is not comfortable with it, I mean, he's perfectly within his rights not to do it. One of the things I do to reassure people is I actually do get an antibody test, a CLIA. So kung IgG positive siya, we know it's not for sure that it's neutralizing antibody, but it's very unlikely that somebody who has IgG will still have viable virus around. But again, ano yan call yan and of course the hospitals also have their own they also have their own what do you call this policies in each the other way to do it if you're just done with testing is just do it under level 4 and get it over with and go from there.
Agree, Dr. Jim. It's hospital policy. Even if you have a different idea and the hospital says you have to follow this, then we still have to comply.
You have no choice. You have to follow. Okay. Please comment on the report that RITM has an RT-PCR test kit that is 100% sensitive and specific.
Yeah, so ganito yan. The RT-PCR kits are very sensitive. The problem is the specimen. Okay? If you use a nasopharyngeal swab, it's only about 70% sensitive. If you use a bronchoalveolar lavage, it's more than 95%. So the sensitivity that we are talking about is not the kit itself. The kit itself is really high, but it's the specimen. Kasi when you swab, hindi naman lahat all the way to the back. Some people are not shedding virus as much. It can be symptomatic, asymptomatic. Tapos how fast you can process the specimen, paano yung cold chain. So that all comes out to about 60 to 70% sensitivity. And that's the reason for it. Not because the test itself is not sensitive. It's because of the whole procedure of getting the specimen.
Here is another question. Most of them are really related to each other. Let's talk about long haulers. Is there such a thing as a long hauler COVID case? And how does GI symptoms figure in this? Do the GI symptoms, are they more prevalent in long haulers? What's the relationship between that?
Yeah, most of the long haulers are actually more lung and cardiac issues. So a lot of them may need oxygen for a long time. They're not infectious anymore. It's really more because of the damage from the virus. So a lot of these are, they need oxygen for a long time or they're really deconditioned. And some people have CHF because it can be cardiotoxic.
But not GI symptoms?
Not that I know of. Maybe Derek knows.
Yes, Dr. Jim. In some of the cohort studies from China and in the US, they look at the length of GI symptoms. And generally, it is about 3 to 6 days. That is the duration of the diarrhea, nausea, and vomiting. And majority were actually 2 to 3 times diarrhea a day. It wasn't really so bad as what we are expecting. No? Because as I mentioned, the entire GI tract is full of ACE inhibitor and ACE receptor. And of course, this may be affected. But most of the studies, the cohort studies, 3 to 6 days, the length of GI symptoms.
Okay, there is a comment here which says that infectious disease recommendations weigh more to the hospital policymakers than the GI recommendations. Any comment on that?
Expected.
Yeah, I think it's hard to make blanket policies in general. And, we review these. There's 2 sets of policies. It's the DOH policy that is guided by PSMID and the other societies, including GI, if it pertains to your particular procedures. But at the same time, there's the hospital policy na bawat infection control. And this is, the reason is because it's really different for each hospital. Iba ang PPE levels mo, iba ang prevalence, iba yung procedures. So I think that between those two, we really have to make sure that we localize. Kasi otherwise, if people are not comfortable, they're not going to do the procedure.
Okay. Here's another lengthy question. The specialty board plans to conduct the written exam on November 8th and will not be an online test. It will be a whole day exam. Face mask, face shield, physical distancing, and will be imposed. PRC recommends conducting the exam during the modified GCQ. Will NCR be MGCQ at the end of the month?
I think GCQ until end of the year.
PRC guidelines recommend mandatory COVID testing for healthcare workers or go on quarantine for 2 weeks. Certificate from the barangay. Plan to do mandatory COVID testing. Can we do antigen testing instead of RT-PCR?
Yeah, probably not for low-risk patients na asymptomatic. It's not designed for that. And even then, may makakalusot pa rin, which is kind of the bottom line. These kinds of testing, screening strategies, and it's not a very high-risk situation, unlike endoscopy. It's very difficult to make a good case for that. But of course, PRC has its own mandate. So, DOH we just released, well, not me, I'm not part of DOH, but I did give some input on the new omnibus guidelines. And it outlines how we should use our tests talaga. And really, in general, asymptomatic screening is probably only useful when there's some really high stakes, like for operations or for aerosol generating procedures. But for situations like this, I think there's not much data. And the other thing is, risk appetite rin yan. Kasi if there is a way to do it online, I would rather do it online. Nakita nyo naman yung hierarchy, di ba? But, that it's a free country.
Right.
Edsel?
Yes,
yes, Derek.
Yes. I'd just like to ask you, because a while ago I was showing the protective effect of each PPEs. You're talking about mask alone, you're talking about face shield alone. What if you have all these 3 or 4? Physical distancing, you have the face shield, you have the mask, N95-1. What's the probability of getting infected?
Yeah, it's a lot lower actually. But the problem is you have to base policy on this, And and it varies kasi in terms of pretest probability depending on the situation. And the problem with saying that, if you cannot say that there is 100% certainty na walang mahahawa dyan, and even if hindi nahawa, baka nag-incubate lang, pero mapapagbintangan ka na that's really the problem there. It's really being able to, exactly. So yun yung may exposure kahit papano And if there's a way to do it where you can eliminate risk, where you don't have to do it person to person, then that's better. The other thing is if you have more than 10 people at the same time, you're going to be violating GCQ rules. And so that's really the problem there. Why sinabi nila dapat MGCQ? If it's GCQ, you can't gather that many people together.
We still have several questions here, but I was informed that we do not really have time for more questions. But anyway, most of these questions are interrelated and have already been answered previously. With that, I would like to thank you both, gentlemen, for your very enlightening dissertations on your respective topics. And of course, the audience does that as well. I'd like to thank the whole audience for their questions and their attention during this very interesting session. I would like to turn over the microphone, the session now to our moderator or convention moderator. Thank you very much.
Thank you, Mr. Chairman, and thank you, Edsel. It was a pleasure to be speaking together with you.
Thank you.
Thank you to our moderator, Dr. Ignacio. Before we proceed to our next breakout session, Dr. Jing Javier would like to say a few words.
A pleasant good evening to everyone. First of all, I would like to thank all our speakers and moderators for their participation in tonight's webinar. Challenging as it is, we continue to face and rise above the situation. The knowledge and insights imparted tonight certainly make this endeavor worthwhile, for it will also help us as we continue to navigate this pandemic. I would also like to thank all our attendees for their time, support, and participation to ensure the success of this webinar. I hope to see you all on October 31 as we continue with our mid-year convention. I enjoin you to visit our virtual booth and interact with our pharmaceutical partners. Again, thank you so much. Stay safe and God bless.
Thank you to all our speakers and moderators, and thank you to all attendees of PSG's Mid-Year Convention. Before we proceed to our virtual room sessions, we would like to thank our sponsors. Abbott Laboratories, Life to the Fullest. Kaufman Pharma. Natrafarm, ang nagmamahal, Natrafarm. Otsuka, Otsuka people creating new products for better health worldwide. Reckitt Benckiser. Takeda Healthcare, better health, better future. Cathay Drug, we learn as one, we heal as one. Fujifilm, never stop advancing healthcare. Eisai, give first thought to patients and their families and to increase the benefits healthcare provides. Just Right Healthcare, your partner in healthcare. Mergers Drugfill, Mergers Drugfill Corporation, quality is our pride. Multicare Pharmaceutical, bringing value to family healthcare. Mylan, better health for a better world. Ventus, empowering life. Servier, committed to therapeutic progress to serve patient needs. SV More Pharma, the Filipino talent is worth the investment in gold. Torrent Pharmaceuticals, not just healthcare, life care. Valor Health. Getz Pharma. Inogen. Westmont. This is just the first part, and we will see you again next week on October 31 for part 2 of this webinar. We would like to remind everyone to visit the breakout rooms of our major sponsors and participate in their activities. Once again, thank you to all our attendees and good evening. Attendees will now break out into our sponsors' virtual rooms. Stand by.